Hello, everyone, and welcome. I'm Debbie Plotnick. I'm Vice President for State and Federal Advocacy at Mental Health America, and it's my great pleasure to welcome you to the Winter Regional Policy Council meeting. I'd like to begin with a very important task, and that's to thank our industry partners who helped to sponsor and make possible this meeting. And here they are in alphabetical order: Alkermes, Allergan, Janssen, Myriad Genetics, Neurocrine Biosciences, Otsuka America, Sage Therapeutics, Takeda Lundbeck Alliance, and Teva. We truly appreciate our partners. This is part one of our winter meeting, and we're going to begin in a minute by saying thank you to state legislative mental health champions. There are a couple of things I'd like to do first. I'd like to also say thank you to our friends at the Council of State Governments, CSG. It's really our honor to have made friends at the national legislator organizations, and you'll hear from one of their members, one of their staff members, in a few minutes as well. I want to remind everybody that today is Giving Tuesday. So if you're so inclined, and we hope that you are, to make a contribution to Mental Health America today, we're so honored that the Hot Topic Foundation is going to match all contributions today on Giving Tuesday to $50,000. So we appreciate you helping us reach that goal. I also want to remind folks that the meeting will be recorded, so you'll be able to tune in later, replay your favorite parts. If you have to leave, you can come back, and you'll receive an email after today's program is completed. Give us a day or two, please, and you'll receive an email with a link that will allow you to play this meeting back again. It really is right now my great pleasure to introduce you to our advocacy manager, Karen Howard. Karen makes all the pieces come together for this meeting, and we're very grateful. And she's going to introduce and be the MC for the portion of the meeting that honors state legislative champions. Karen?
Hello, everyone. Thank you so much, Debbie. As mentioned, I'm Karen Howard, MHA's Advocacy Manager. And as you may know, Health America is known for our Before Stage 4 philosophy, which is promoting prevention for all, early integrated services and supports for those at risk, early intervention for those at risk, integrated services and supports that are community-based for those who need them, with recovery as the goal. As individuals and organizations continue revised operations and activities due to COVID-19, MHA screening data has seen dramatic increases in the number of people coming to take a screen and the severity in the ranges of tests that they're taking. And this is demonstrating a need for both short-term and long-term policy changes. We've seen some state legislatures already take lead by making it easier for youth and adults to connect to needed care via telehealth laws, such as Colorado, which recently passed model telehealth expansion legislation, ensuring parity in telehealth services. And there are other legislators pushing for additional support for services that are community-based and trauma-informed across the country. Most states have covered peer support specialists in Medicaid, and California is the last state to do so in September of this year. MHA's Regional Policy Council brings together experts from MHA's affiliate field who work with their legislators and those who desire to build stronger working connections with their legislators, both state and federal. These annual meetings, which are now virtual, but typically are attended in person by affiliates, legislators, industry partners, and behavioral health stakeholders, facilitate networking and information sharing between states for collaborative advocacy, and recognizes state legislators for leadership in the mental health and substance use fields. Overall, Mental Health America has recognized over 100 state legislators and 4 special governors from over 30 states with our Before Stage 4 Leadership Award and our Mental Health Champion Legislative Award over the last 5 years. It's our great pleasure to continue this tradition despite a different field this year, recognizing leaders from both sides of the aisle today, including legislators from small towns, big cities, legislators with lived experience, and legislators who are caregivers, legislators who are new to their post as freshmen, as well as legislators with decades of experience. MHA is proud to honor 7 legislators today from 5 states. And now we have a welcome message from Sierra Hatfield from CSG, a very close organizational friend of the RPC, followed by awards presentations, thanks to our affiliates in Colorado, Ohio, Oklahoma, and New Jersey. And then we'll have closing remarks from our 2017 mental health champion, Joan Balweg from Wisconsin, and our last year 2019 mental health champion from Hawaii, Representative John Mizuno. Take it away, Sierra.
Hello, this is Sierra Hatfield, and I'm a policy analyst at the Council of State Governments. I am honored to come to you live and in stereo to congratulate all of this year's state legislative mental health champions. Now more than ever, mental health is a critical facet of our healthcare system as we battle a virus that threatens to isolate us and destabilize the things we've come to rely on for security and comfort. As a testament to the incredible resource Mental Health America is and has been to CSG, I can point to the work I've done with Debbie Plotnick as we discussed these issues over the past year as part of CSG's Healthy States National Task Force, wherein my subcommittee, led by Representative Bridget Kelly of Ohio and former mental health champion Representative Steve Ellison from Utah, heard from Debbie as we all sought to provide best practices to states regarding parity, suicide prevention, telemental health, treatment for substance use disorders, and more. As we anxiously await for the final publication of their findings to be released this month, I am again honored to recognize 7 more mental health champions who are tackling these same issues with the drive and determination necessary to heal the mental state of the country. They are Senator Mayfield from Florida, Representative Kennedy and Senator Rankin from Colorado, Representative Dunnington from Oklahoma, Speaker Cowland from New Jersey, and Representative Crawley and Representative Russo from Ohio. I want to extend a thank you to Mental Health America for their work in the fostering and rewarding of innovation in the mental health care field. A thank you to this year's champions for being those innovators, and a thank you to everyone in attendance for caring about these issues and doing your part. This is Sierra Hatfield of CSG, signing off.
Mental Health Colorado is proud to nominate Representative Chris Kennedy for Mental Health America's Champion of Mental Health Award at the Regional Policy Summit this December 1st. Representative Kennedy is known within the legislature and beyond for his expertise in healthcare issues in general and for his deep concerns for behavioral health more specifically. Over the last few years, Representative Kennedy has sponsored no less than 5 bills on substance use disorders, including the expansion of MAT treatments, expansion of housing vouchers for individuals experiencing substance use disorders, and enhancing treatment for substance use disorders in the criminal justice system. Representative Kennedy is very active in hospital transparency and hospital community supports legislation, as well as continuing to work on a public option for healthcare coverage in Colorado. Representative Kennedy has scored 100% on Mental Health Colorado's legislative scorecard every year for the last 4 years. We thank Representative Kennedy for all his great work.
My name is Chris Kennedy, and I represent Lakewood and Central Jeffco in the Colorado House of Representatives. Thank you so much to Mental Health Colorado for nominating me for recognition in mental health policy this year. I'm grateful that I've had the opportunity to work together with your lobby team and your policy experts at the Capitol, mostly through my work on the Opioid and Other Substance Use Disorders Interim Committee. We have together come up with a lot of great ideas to help move Colorado forward, help provide a more robust structure for prevention, treatment, and recovery for substance use disorders in Colorado. And I'm really proud of what we've achieved together. So thank you once again for this recognition. I'm really honored, and I look forward to continuing this work with you in the years ahead.
It is my honor to introduce to you Colorado Senator Bob Rankin. Senator Rankin has been in the Colorado House of Representatives for 4 years and in the Colorado Senate for 2 years. He was just reelected to the Senate for a 4-year term. He serves on the Appropriations Committee and is one of the 6 members of the Joint Budget Committee. And it is on this committee, which is tasked with writing the state budget, that Senator Rankin has shown his support for mental health and substance use funding. Senator Rankin sponsored the state adoption of the Federal Families First Act. He supported reimbursement for telehealth services. He supported improvements in the Safe to Tell program in our state. And he supported Medicaid buy-in option for individuals over the age of 65. In addition, Senator Rankin sponsored House Bill 1393, which expanded the mental health diversion pilot program in our state. Mental Health Colorado is pleased to nominate Senator Bob Rankin for Mental Health America's Mental Health Champion Award.
Thank you, Mental Health Colorado. It's been an honor to work with you. We've had great successes in working on crisis response, and we have a lot more work to do, but we have a good start on integrating mental health with physical health. We have a challenging future, but I know you're up to it with difficulty of recruiting staff and with the problems caused by COVID. So I really look forward to continuing to work with you. Thank you so much for this honor.
Good morning. I'm Barb Johnston from MHA in New Jersey, where I'm the Director of Policy and Advocacy. And today, it's my honor to nominate Speaker Craig J. Coughlin for the Mental Health Champion Award. We're pleased to recognize Speaker Coughlin for his work to promote access to behavioral health care to the citizens of New Jersey. Craig Coughlin is the Speaker of the New Jersey State Assembly, a position he has held since 2018. He was elected to the New Jersey Assembly in 2010, representing District 19. He's grown to be one of the most respected voices in our New Jersey State Legislature. He's always been a strong supporter of mental health and substance use, all of our initiatives. He supports these issues with a depth of understanding and passion, and he is known throughout the state for his ability to make legislative change. He was a major champion on the passing of the parity legislation in New Jersey when he was then Assemblyman Coughlin. He worked with the community from the inception of the bill to the final passing of the law. Our New Jersey parity law requires measurement, accountability, and transparency for several complex state and federal parity laws. These laws require that restrictions for behavioral health be no more stringent than for physical health. Under his leadership, successful negotiations throughout the process, and especially in the final days, allowed this bill to be passed into law. Speaker Coughlin's support of mental health has continued throughout the pandemic. He's co-chair on a select commission for funding pandemic-related initiatives. And proudly, our state has recognized the importance of continued and enhanced funding for mental health, especially at this time for our citizens. We all feel very fortunate to have Speaker Coughlin as a legislative leader in New Jersey. Thank you, and congratulations on this honor.
Thank you, Barbara. It's an honor to be recognized by Mental Health America. I apologize for not being able to accept this award many months ago in Kentucky. It would have been an opportunity to meet you all, and I wish I had had it. But my, how the world has changed since. Now more than ever, your work is so incredibly important as we fight on so many fronts: death, sickness, job loss, fear, stress, and loneliness are just a few things that come to mind. COVID-19 has not only driven spikes in anxiety and depression, but it's pushed our fight against substance abuse off the front page. Group therapy and other forms of treatment have been disrupted or halted for months at a time. Worse yet, we're seeing a resurgence of substance abuse after promising gains. And I imagine the same is true for alcoholism in a time of such darkness and uncertainty. No community, race, or gender has been immune to the mental health challenges this deadly virus has brought to us. My colleagues and I stand ready to continue to partner with you in this fight. Access to mental health care is truly more important than ever. Payment parity and fully funded services for children, adults, and seniors are absolute must now and post-COVID. It will take years to return to our pre-COVID gains, but I have great faith in all of you. And you can count on my support, along with that of my colleagues like Joanne Downey, Valerie Veneri Huddle, Herb Conaway, Majority Leader Lou Greenwald, Shavonda Sumter, and of course, my running mate, Joe Vitale. We're fortunate to have so many committed legislators to mental and behavioral health. Once again, I thank you for this great honor. Please have a happy Thanksgiving and a safe and happy and healthy holiday season.
Hi, my name is Tanya Fullwider. I'm the Associate Director of Mental Health America of Ohio, and I'm thrilled to have the opportunity to introduce two legislative mental health champions in our Ohio General Assembly at today's Regional Policy Council meeting. Representative Erica Crawley, serving in her first term in Ohio's District 24, hit the ground running as a fierce advocate for children, as she says, from cradle to career, for those who intersect with the justice system, and lifting up policies addressing the many racial and socioeconomic inequities in our state. One of our agency's largest programs serves pregnant and parenting women with mental health complications, and Rep. Crawley's advocacy on maternal and infant health has been strong and steadfast, and we look forward to working with her into the next session. Rep. Crawley also serves as a member of our Suicide Prevention Coalition here in Columbus, and she shared her time, her policy expertise, and her own personal experiences around the topics of mental illness and suicidality this fall with nearly 500 clinical providers at our annual mental health conference. Representative Crawley, we truly appreciate you. While Representative Dr. Allison Russo is also in her first term and serving District 26, she is no stranger to mental health policy, having spent 2 decades advising leaders and policymakers on issues related to affordable and accessible healthcare. She recognizes MHA's before stage 4 philosophy with her understanding of the value of evidence-based prevention and early intervention. Our agency is a member of the Ohio Parity Coalition, a group of 27 advocacy organizations, and our goal is to eliminate discriminatory barriers to mental health and substance use disorder care, ensuring that people have access to care that they're entitled to receive. And we're proud to support Rep. Russo's House Bill 443. Last December, she introduced this important legislation to address access to mental health and substance use disorder treatment. The Mental Health Parity and Addiction Equity Act, bipartisan legislation that would align Ohio's mental health parity laws with current federal law, raise awareness for individuals and employers for their rights and responsibilities, and enable better implementation and enforcement. We are grateful to have Representative Russo as an advocate in our state. Thank you, Mental Health America, and Representatives Erica Crawley and Allison Russo.
Hi, my name is Erica Crawley, and I am a state representative for Ohio's 26th House District, which is East and Southeast Columbus. And I just want to say thank you to Tanya Fullwider for nominating me for this award today. And I want to say thank you to Mental Health America and Mental Health America, the Ohio affiliate, for selecting me to receive this award. I am truly, truly honored to be recognized in this space. And I just want to talk about why it's important for me to be a mental health champion. Since I came into the legislature 2 years ago, I have been very open and honest about my experience with major depression as someone who has been diagnosed at the age of 16 and have experienced this throughout my adult life, but as one who have been able to live a full, healthy, and happy lifestyle. I also think it's important for me to be a mental health champion as someone who is a Black female living in the Black community and understand how our community continues to be burdened around the stigma with addressing mental health services. And in Black and Brown communities, there is a fear that if they go seek treatment or counseling for something that may be more than just a bad day, that they will have a diagnosis where other people may not understand what they're experiencing. So I just want to make sure that I am talking about awareness and access in a way where everyone feels like they can get the help that they need. I also think that it is important for me to be a mental health champion as a veteran, understanding how our service members who go off to war and come back and transition into civilian life often suffer from PTSD, and we see that the suicide rates among our veterans continue to increase, especially for Black males. It's also important for me to be a champion as someone who is perfectly situated in the legislature as a member of the House Finance Committee, where I get to work with my colleagues and prioritize funding around mental health access, as well as substance use access for treatment and addiction. I also get to craft legislation around access to treatment, and two pieces of legislation that I'm currently working on and have garnered a lot of support around is House Bill 720. House Bill 720 requires de-escalation training for police officers and ongoing annual training around how to engage with someone who may be experiencing a mental health crisis and be able to assess that situation where they can call a social worker or a behavioral health specialist to come and help de-escalate that situation. We see in our political environment now, especially among Black males who are experiencing a mental health crisis, when they engage with a police officer that was called, it often results in someone losing their life, and that is unfortunate. It also requires racism and cultural competency training so that we don't see a disproportionate impact and the loss of life among Black and Brown people. Another piece of legislation that I'm working on is perinatal mental health access. And I think it's important, especially for birthing persons, to be able to have access to care during their pregnancy and postpartum period, where they can develop those positive social and emotional bonds with their infant. And so I will continue to be a mental health champion while I'm in the legislature and after as just a regular community member. And so I just want to say thank you again for this award today.
Hi, I'm State Representative Allison Russo, and I represent the 24th House District in the state of Ohio. First, I want to say thank you to Mental Health America for this recognition as a legislative mental health champion. I am both so honored and humbled by this recognition that you are giving to me this evening, and I appreciate that. And I appreciate the work that you and your organization does continually and has done for decades. I want to say that certainly we have faced many challenges in the mental health and behavioral health field before COVID-19. Specifically in the state of Ohio, we dealt and have been dealing with an addiction crisis. We have been dealing with rising suicide rates, and we have been also trying to tackle the toll that social isolation plays, particularly among our senior population. But with COVID-19 and the economic recession that has followed, we have new challenges in this space, as many of our residents and citizens face more social isolation, as they face job loss, as they face anxiety over what is happening with their health as well as their family members' health. And as we think about our frontline health workers and the burnout that they are facing as they continue to go on 8 months of dealing with this crisis. And so that brings a renewed sense of dedication to these issues, making sure that we are increasing access to early intervention. Even when we face challenges in getting individuals into see providers, we need to make sure that we are providing every opportunity possible for patients to get access to needed care, making sure that we are expanding our mental health and behavioral health workforce, which has been a challenge in so many areas, particularly here in Ohio. Ensuring, and an issue that I've worked on that's very close to my heart, ensuring the enforcement of payment parity for our mental health services, and that individuals can get the care that they need and the care that they deserve. And also making sure that we are integrating mental health and well-being into our school policies and our school financing plans. And finally, addressing head-on the toll that racism takes on both our public health as well as our mental health among our Black and Brown communities. So this current situation and pandemic gives rise to these new challenges and a renewed sense of dedication. And I thank you and the work that Mental Health America is doing. And I promise to continue to be a champion in this space and know that I have you behind me and we will keep moving forward. Thank you.
Hi, I'm Terry White, CEO of Mental Health Association Oklahoma. I want to congratulate Representative Jason Dunnington on being the recipient of Mental Health America's Legislative Champion Award. I'm excited to introduce Representative Dunnington, not only because of his great work, but also because he's my personal representative as a resident of Oklahoma House District 88, a great person, and my friend. He's been a leader in our state by authoring House Bill 3872, the Youth Mental Health Protection Act. This legislation prohibits licensed medical practitioners from providing conversion therapy to anyone younger than 18. Conversion therapy is a widely discredited practice that seeks to change a person's sexual orientation or gender identity. Thank you to the Trevor Project for nominating Representative Dunnington. Thank you to Mental Health America for recognizing the hard work happening in Oklahoma to protect the mental health of our young LGBTQ citizens in our state. And thank you, Representative Dunnington, for working tirelessly at the state capitol to advocate for the mental health and well-being of all Oklahomans.
Good morning, everyone, and thank you for giving me the opportunity to be with you all this morning. What an honor it was to receive a phone call from Mental Health of America and be told that our work here in the state of Oklahoma was going to be honored for stepping up and trying to do what was right when it comes to ending the practice of conversion therapy. What a crazy year 2020 has been, and it could not be a more important year for us to focus on things like mental health. As you all know, being in the profession of mental health, this year, more so than probably any year that I've been alive, has been one that has caused great stress on families and individuals and their mental health. And so I just want to take this opportunity this morning to thank you for the work that you do in the lives of your communities, in the lives of your states, and in the lives of those of us all in the United States of America. I thank you from the bottom of my heart for the work that you do. Again, I was very honored to learn that the work that we've been trying to accomplish here in Oklahoma on banning the practice of conversion therapy was going to be honored by a national organization such as yours. It's such important work. You know, many of you may know that Oklahoma is a conservative state. And while I know and you know there at the conference that things like conversion therapy have nothing to do with being conservative or being liberal, with being Republican or being Democratic, that conversion therapy is a practice that's harmful to children. And that was what we tried to relay to our colleagues here in the state of Oklahoma. And we were successful in getting this bill out of committee. And while some of you from much more blue area states might think, well, that's not that big of a deal, it was a huge first step in the state of Oklahoma for us to have this conversation in the open to talk about the harmful effects of conversion therapy on young men and women in the state of Oklahoma. And so it was a great honor for me to have the opportunity to work on this bill. We look forward to continuing to push it and move it forward here in the state of Oklahoma. Every child deserves to feel safe and secure, and to not have something as dynamic as their own sexuality challenged by forceful therapy, trying to get them to believe there's something that they're not. So we hope to see this work continued here in Oklahoma. I thank you again. I'd like to also thank the Trevor Project for being so influential in helping me here in the state of Oklahoma with both resources and data and just being available to help me on this journey to try and get conversion therapy into the state of Oklahoma. But I want to thank you again this morning for the work that you do, and be well the rest of 2020, and let's all hope for something better in 2021. Thanks again.
Aloha, this is John Mizuno, State Representative from Hawaii. I wanted to thank Mental Health America for the award I got in 2019 in Puerto Rico. And to the awardees today, I want to congratulate all of you for a job well done. I think it's important to note that amid the pandemic, it's okay to say, I'm not okay and I need help. Again, especially because of the undue and extreme stress that the COVID-19 pandemic has caused throughout our world. So we can focus on that theme and share with our people if they need help, to get the help they need, and be willing to provide professional services for those people in need. I did again want to commend and congratulate Mental Health America for the great work you do and all of the honorees. And finally, as we move forward through this pandemic, let's continue to focus on education, awareness, and harm reduction for people with mental health condition and or a substance abuse disorder. Again, on my behalf, I just want to thank you for the great advocacy you have done and the lives you have saved, and the lives you will continue to save. God bless you all. Take care.
Hello, I'm Wisconsin State Representative Joan Baldwin. Wanted to be here to congratulate all of you who have been awarded the Mental Health Champions by Mental Health America this year. Those are Senator Mayfield from Florida, Representative Kennedy and Senator Rankin from Colorado, Representative Dunnington from Oklahoma, Speaker Coughlin from New Jersey, and Representatives Crawley and Russo from Ohio. I know as a former awardee that this is a very good way to help legislatures and legislators across the nation replicate good government and good policy. Thank you, Mental Health America, for highlighting these champions for mental health this year.
Hi, it's Karen again, and I wanted to take the opportunity to remind or introduce you to the Back Home campaign. This is an initiative based on relationship building between MHA affiliates and their federal and state officials. When elected officials hear from affiliates about how legislation impacts them, affiliates become a trusted source to inform legislative hearings, legislation, and other considerations. Just this year, affiliates have participated in grassroots and grasstops activities, such as emails to Congress, meetings with legislators, phone calls, and even social media messages posted on Facebook, Town Hall, or Twitter. When officials trust affiliates, actions they're come to as a source of information, and their actions mean more at the official level. Some affiliates have invited legislators to tour their facilities, and even through COVID, I'm thinking of possibly setting up a virtual tour, a virtual meeting, in order to remind the legislator of the importance of the work that you affiliates are doing. Actions that affiliates have taken this year have led to two major wins for the mental health community. Passage of a statute in the CARES Act, passed in March, to conform 42 CFR Part 2 with HIPAA, the Health Insurance Portability and Privacy Act, as well as passage of the National Suicide Designation Act, which the House of Representatives passed in September after the bill had really just been sitting in committee for months after passing in the Senate in May. Due to the groundswell of support, the House of Representatives also passed this second bill, the Suicide Designation Act, which designated 988 as a 3-digit number to reach the National Suicide Prevention and Mental Health Crisis Hotline. And we say the pressure from back home in the state or in the district from which the official is elected is critical to making this progress. So shout out to our affiliates. I wanted to remind all advocates, as well as researchers and community members, that MHA's position statements are comprehensive statements about how MHA envisions the ideal mental health systems and supports for individuals in the US. These position statements are available on our website at mhanational.org. If you hover over the policy tab and then drop down and click position statements, you'll find over 50 position statements with topics ranging from systems transformation, including parity and behavioral health integration, to human rights, as well as early intervention in childhood, juvenile justice, criminal justice issues, and the most recently written position statement on the increasing community violence and how that is traumatic to the human body and mind. So affiliates are welcome to repost these statements on their websites. We encourage everyone to use these position statements to inform themselves, their families, their communities, and government officials, because legislators really need to hear from the mental health community to know what to prioritize about when budget committee hearings come up or decisions about funding comes up. It's helpful to know how many people are reached by our affiliates, what existing resources are being utilized and how far are they going, and also what challenges have come up since COVID. Some affiliates have set up additional warm lines, emotional support lines for healthcare workers. If legislators don't hear from you, then who will they hear from? With that said, thank you so much for tuning in to the Legislative Awards ceremony. We really appreciate your time, and I will turn it over to Debbie.
Thank you, Karen, and congratulations to all of our mental health champions who received their awards for the entirety of 2020, as well as our awardees this morning. We, as you can see, mental health champions come from every state in the nation. They come from both parties. They come from all neighborhoods, and we're so proud of them. We really appreciate it. We're going to take a short break. We'll be back at 11:45. Please join us as we get into some terrific policy discussions. See you soon. Hello again, and welcome back, or welcome for the first time. I'm Debbie Plotnick. I am Vice President of State and Federal Advocacy at Mental Health America at our national office, and I'm joined by Mo Keller, who's the Director of Advocacy at our wonderful affiliate, Mental Health Colorado. I'm going to turn things over to Mo in just a second, but I want to start with some very important housekeeping. I want to thank our industry partners who help make this meeting possible. Alchemies, Allergan, Janssen, Myriad Genetics, Neurocrine Biosciences, Otska America, Sage Therapeutics, Takeda Lundbeck Alliance, and Teva. And Mo's going to give you a little bit of history about the Regional Policy Council and why we are so proud to have this meeting. But I just want to take 1 minute to say how proud we are to how, as one of Regional Policy Council representatives. She's been with the Regional Policy Council since its inception. She's been with Mental Health Colorado since 2010, so she's been there for 10 years. And before that, Mo was a great, although unrecognized at the time by us, mental health champion. Mo has a history as being a representative in the Colorado legislature and a senator again in the Colorado legislature. And I just love it when we walk down the street in Denver and people come up to her and say, "Hello, Senator." So she'll always be my favorite Colorado Senator, Mo Keller.
Thank you very much. Appreciate that. And welcome to everyone who's joining us. It is my pleasure to introduce you to our Western States Regional Policy Council Summit. Mental Health America established the Regional Policy Council in 2009 to work with our Public Policy and Advocacy Department in achieving policy goals in a coordinated and effective manner. The intent was, and still is, to provide a way for Mental Health America to bring mental health care home, meaning to activate more successfully our state affiliates' contacts with our state legislators in effecting policy change. The Mental Health America Regional Policy Council cultivates a constructive partnership with its affiliate field, which includes more than 200 state and city affiliates in 41 states. We join with state policy leaders and local policy leaders and other mental health stakeholders. We work together to initiate, advocate for, and implement federal and state policies that positively affect children and youth and adults living with mental health and substance use conditions. There are 4 policy councils. We have the Northeast, Middle America, the Southern region, and the Western region. Mental Health Colorado has been the Western region policy lead for close to 10 years now. We meet virtually each month with our Western state affiliates to discuss mental health issues nationally and in our individual states. Our Western states share various legislative ideas, legislation that we have passed in our different states, and we provide resources to each other and supports to each other in advancing policies that we all have in common but are individualized to our states. The Western region shares issues that are unique to our area of the country. We all have vast geographic distances. We have great rural sections in our states, and we have indigenous populations in larger numbers than many other areas of the country. We share more agricultural areas with unique mental health needs than other areas in the country. And we tend to have a streak of independence here in the West that can hinder reaching out for help when experiencing mental health conditions. In the last few years, Mental Health America has coincided our regional meetings with the conventions of 4 national legislative policy organizations. And that's the National Council of State Legislatures, the American Legislative Exchange Council, the Council of State Governments, and the National Governors Association. And this enables us to reach more state legislators to advance our mission of improving access and care to individuals experiencing mental health and substance use conditions. So, with that history, I want to thank you again for joining us today at our Western Regional Policy Summit. And I know you will benefit from hearing our great lineup of speakers. We have a really great day planned for you. And with that, I'll turn this introduction back over to Debbie. Thanks.
Thank you, Mo. And again, thank you. And again, thank you to our industry sponsors, because I can't thank them enough. Our partners, they really help us. I'm going to run through that list real quick. Alkermes, formerly known as Allergan, now known as AbbVie, Janssen, Myriad Genetics, Neurocrine Biosciences, Otsuka America Pharmaceuticals, Sage Therapeutics, Takeda Lundbeck Alliance, and Teva. Today's meeting is being recorded. You will be able to view it shortly after the meeting. You'll get a link to where you can listen to recorded sessions, and please share them with your friends and colleagues, and especially legislators all over the country. I want to take a minute to talk about what you're going to hear in today's meeting. We really take very seriously the injustices and inequities that really have been plaguing our nation, perhaps from the very beginning. I would say more than perhaps, definitely from the very beginning. And we see that when it comes to mental health. We see it right in front of our faces. We see racial disparities. We see inequities. We see people ending up in the criminal justice system. So today's meeting is going to look hard at those issues. We're going to begin with Dr. Jack Rosell, and I'll introduce him in a minute. But he's going to show us a terrific program in Western Pennsylvania, something that we hope will happen all over the country. We're going to then move to Carol Ballard from CIT International. And Carol is going to really help us understand the where we were, the how things have changed, and a little bit of thinking about how do we get back to that. We're then going to hear from Mary Van Hout, who teaches police officers. She does suicide prevention training. She herself is a family member. You'll hear from her about officers' side of mental health. We're going to then feature some phenomenal programs out of Colorado, based at our Mental Health Colorado. We're going to hear from its executive director about their Cares Not Cuffs program, and we're going to see and hear about a program that is taken from a national model and is starting up in Denver called the STAR program. And then we're going to take a look, and Mo will be doing the moderating this panel of our affiliates, of Mental Health America affiliates, and talking about a group of citizens that we often don't pay enough attention to, and that's indigenous populations. So Mo will be leading a panel of our affiliates on what are some of the issues that they are doing in their states, and what are the issues that are facing indigenous populations, especially in the time of COVID. I'm really honored and thrilled to have Dr. Jack Rosell be joining us. Dr. Rosell has more than 30 years experience in emergency mental health. He's a psychiatrist who is widely recognized. He is the head of the Emergency Psychiatrist Division of the American Psychiatric Foundation. He heads up the, let me get that title right, American Association for Emergency Psychiatry. He directs an amazing center in Western Pennsylvania, my home state, not the state I presently live in, and we'll be hearing a lot about that. Dr. Rosell has been recognized as a distinguished fellow by the American Psychiatric Association, Behavioral Health Professional of the Year from CIT, which you'll hear more about a little later in the program, and Dr. Jack has been given awards from many organizations, and we just think he is phenomenal. I think you will too. So I'm going to turn things over to Dr. Jack Roselle.
Good afternoon. My name is Jack Roselle, and I'm going to chat with you for the next little bit about what I think we have in front of us as the future of crisis intervention in our country. Now, over 30 years ago, I got my start as a volunteer to suicide hotline, and I got bit by the bug, and I never really turned back. And I've been working in emergency mental health in one way, shape, or form ever since then. Today, I'm going to tell you a little bit about where we are today with emergency and crisis services and where we should be going next. Now, by the way, I'm happy to share all these slides and the resources that are behind them. My contact information will be on the last slide for you to copy down. Well, it's been a rough year to think about crisis services and what crisis services can and should be. And what I'll begin with saying is that if your community relies, as most do, on law enforcement to respond to people in crisis and families in crisis, you're relying on people who are screened and trained around the use of force, including lethal force. You're relying on people who are managed around arrests and, how they're solving crimes, not necessarily de-escalation and how to engage with people in the community. And while most of these interactions go well, and while law enforcement response is useful and sometimes essential in crisis response, sometimes it can go awry and sometimes it can become deadly. When calling for help before crisis becomes that perilous moment of questioning of, if I call this person to help me, to help my loved one, will it really go okay? When we're calling for law enforcement, we're bringing armed professionals to a home where a person may be suicidal and the addition of a fire may be the last thing we wanted to see. When we're calling for help in a crisis, we're dealing with issues of intersectionality, the layers of living with mental illness, living with substance use, the experience of Black, Indigenous, and people of color in a system that has a very real legacy of white supremacy, both in law enforcement and in emergency mental health. We need to find ways to understand and to reconcile and to mitigate the risks of that. Over the past year, we've heard the stories of many people like Elijah McClain, Daniel Prude, Walter Wallace Jr., people with psychiatric emergencies or major psychiatric issues who, at a time of crisis, instead of being met with support, instead of being met with help, lost their lives. And that is, needless to say, the worst conceivable outcome for anyone in crisis. Well, maybe the metaphor that we should be looking at is not necessarily an analogy to law enforcement and how law enforcement responds, but maybe how firefighters respond. Years ago, I was at a party chatting with one of my coworkers who was also working in sort of acute care settings, and we were joking about how we felt like we needed, fire helmets because we're always running around putting out fires. And one of the other folks at this party, actually one of my colleagues' dads, who was this sort of salt of the earth firefighter who'd been in the field for his entire life, says, son, let me explain something to you. I said, most of the time, we're not wearing that helmet. We're not in the jump gear. We're wearing the watch cap. And we're driving around the neighborhoods and learning the routes. We're knocking door to door and checking smoke alarms and fire extinguishers and teaching fire safety. We're practicing, we're drilling, we're studying how to do our work better. Because when people are calling for a firefighter, just like they're calling for a crisis intervention professional, they're in crisis and you don't have time to mess around, and you've got to make sure that the folks are trained and ready to go. And maybe that's a good metaphor for what we do in crisis work as well. Instead of running from crisis to crisis to crisis, how can we make sure that we're intentionally building in the planful strategic aspects of getting ready to serve our communities? In fact, I'd suggest maybe that if we are running crisis to crisis, it might be evidence of an under-resourced program. Prevention, preparation, and planning can be critical. Now, by the way, planning has its limitations, right? Resilience and humility are a big part of doing crisis work. But there's also value in the planning of having at least a framework to build off of in that heat of the moment response. Whether it's for that individual crisis clinician that reports up to me who's out in the field knocking on someone's door, whether it's for my own leadership team as we try to decide how to navigate the next major, social hurdle or community event. I'll give you a moment to look at this cartoon. As you do, I'd suggest that if you think of this as an emergency psychiatrist, that traditional, hospital-based emergency setting where you're trying to decide, gosh, what's the DSM diagnosis that helps me understand this person? What's the medication we might give that person? Are we going to admit them or discharge them? That those questions don't yield a very useful answer in this situation. I can't fix this type of a crisis with a psychiatric admission or even a psychiatric formulation. And I'd suggest that our colleagues in law enforcement really can't fix it with a criminal code or an arrest either. Just because the only tool we have is a hammer doesn't mean that everything is a nail. And good crisis work is very much about creative problem solving and looking outside of the box. Now, at a basic level, we do have to think about what is a psychiatric emergency, what has to go to that emergency department. And as an arbitrary definition, it's anything that's life-threatening or appears to be life-threatening, and that we need that skilled subject matter expert, the psychiatrist, psychologist, that nurse practitioner, someone looking at that person in crisis, coming up with a diagnosis, coming up with an intervention. And if they aren't there, if they're not getting it right, then you know what? Something really bad could happen. Someone could be injured, someone could die. And we're looking at a real basic formula that if someone has the right diagnosis and they have enough dangerousness, if they're suicidal, if they're aggressive enough, then those two things together come to admission, right? That's sort of the outcome of the emergency psychiatric intervention. Commonly across our country, these are people going to the general emergency department, often without a ton of other resources to help people with psychiatric or behavioral emergencies. Somewhat better are centers that have specialized psychiatric assessment and consultation, even through teleservices. Even better still are embedded psychiatric evaluation areas and dedicated staff. The best in class, arguably, is the psychiatric emergency service as a standalone area with separate space and specialized staff. It's ideal, but it is uncommon, even in our most well-resourced areas. Alternatively, think about crisis, right? This is a situation where someone says, I need help, right? It's about assistance and support. It's about my own coping resources or my own sort of natural network of supports being overwhelmed by the exigent circumstances that I'm in. And it may be because of my own lack of resources, my lack of coping skills, or it may be because they're just not enough to deal with the crisis that I'm facing. Here we think about distress plus dialogue equals assistance, right? Now, common crisis services cover a pretty broad range. Dr. Anita Everett, who's the medical director at SAMHSA, talks a lot about her core model of crisis, of someone to talk to, someone to come to you, someplace to go. Someone to talk to means our traditional phone services, 1-800-273-TALK. Crisis text and messaging services are available in many areas, specialized crisis lines for sexual assault, for LGBTQ issues, for other issues. Coming by July of 2022, the transition to 988 for all the National Suicide Prevention Lifeline partners, I think will have a huge impact. Somebody to come to you, someone when you're in your time of crisis who can be knocking on your door, sitting on the couch next to you, there to offer compassion and offer guidance. Mobile services, in-home crisis support, and yes, integrated mental health, law enforcement, paramedic types of response models that we've been talking about so much recently. Someplace to go, walk-in centers or drop-in centers, short-term crisis stabilization and residential programs where people can stay instead of for hours, they can stay for maybe a few days up to a week. Extended respite and transitional housing programs. And then sometimes we've got to have something more, which is when we're offering disaster response to the community, critical incident stress management and support for our first responders and our other impacted healthcare professionals. And of course, threat management, where we're blending the resources of emergency mental health with law enforcement to try and prevent terrible acts before they occur. Now, one of the important lessons I've learned over the years is however I might want to define crisis or emergency services, or however you or your payment systems might want to define it, someone in crisis really doesn't care. And the time I've been at Resolve Crisis Services here in Pittsburgh, we've had well over 1 million calls coming into our center. And I can tell you, no one has ever called up asking about our criteria for services, right? They're not calling, does it have to be this, level of illness for this type of a billing code or something else? People don't care about that. They're calling and they're saying, I'm scared, I'm hungry, my loved one is ill, can you help us, please? And they're going to reach out to whatever program was most helpful last time. Or maybe if they've worked with 3 or 4 different programs over the time, maybe, unfortunately, the one that was least toxic to interact with. Good crisis services, in fact, all good emergency services, have to be really good at figuring out that when that person is reaching out for help, how do we link them to the right type of services? Triage is not the patient, the consumer, the family member's responsibility. It is the system's responsibility to do it in a way that's efficient and compassionate and timely. Well, what can crisis services do for you? What can they do for your community? There's a lot of different ways to look at this. We have our traditional crisis services. At our program, we call them our core four programs, our telephone services, our mobile crisis services, our walk-in services, our residential, right? We offer all of these around the clock, 24/7 to the greater Pittsburgh region. Pretty common model. Again, that core elements of someone to talk to, someone to come to you, and someplace to go. These programs can serve a lot of different parts of the systems in a lot of different ways, right? A lot of times, and I hate the phrase problem patients because usually it's the system that's having the problem, but the patients who just don't fit well into that traditional medical ED service delivery model or the law enforcement response model or the inpatient treatment model that just aren't fitting there. Well, guess what? Maybe we can be a little bit more flexible out at our crisis center and find a way to help them, find a way to engage them, keep them from being that frequent presenter into the emergency department. That person is calling 911 multiple times a day. Sometimes it's a safe place for someone to meet their service providers, other members of their treatment team, family members who may not have connected with them in a while. We talk a lot about that getting to yes mentality. We know what we can do, and a lot of times someone will call us up and say, hey, this is the situation, can you help? And I might say, oh, that's new. We haven't done that before. But the next thing is I want to figure out, how do we do that? How can we help with that? Okay. We talk a lot about harm reduction and mitigation. We talk about ways to divert people from inappropriate use of inpatient settings, diversion from criminal justice or legal interaction. We talk about ways to help people step down from inpatient, right? They've been on inpatient for several days. Now they're just waiting for a rehab bed. That might be more appropriate for them to be in my setting than using up precious inpatient space during that gap. And part of this is about accessibility. Again, people don't have crises 9 to 5, Monday through Friday. In fact, I'd give my eye teeth just for one big messy case that starts off on a Monday morning instead of a Friday afternoon, right? So we make our services available 24/7, 365, and that's both on the phone, in person, and out into the community. And we're really lucky here in Pittsburgh and in Pennsylvania because of our payment structures that we're able to do this without charging a fee to any individual. There's no direct billing, there's no copay, there's no back billing, there's no your insurance covers the facility but not the doctor junk that people might have to deal with. We want to make it as easy as possible for people to reach out for help. We want to make it as destigmatized as possible for people to reach out for help. And we build a lot of this around recovery-oriented and person-centered crisis services. And unlike some crisis centers that have been around for a long time and frankly have done a really nice job and said, recovery model, this is popular now, our program was actually built from the ground up about 12 years ago around the recovery model. And that's about helping each person find the best solution, linking them to the right kind of services. Not what's a good fit for us as a system or as a provider, but what's the right fit for them? Where do they need to be geographically? Where are the right services? Where are they likely to have a good experience versus a bad experience? It's not about internal routing of services. It's about what's right for the consumer. It's about building on natural strengths and supports, identifying the self-determined goals and priorities. It's about embracing the dignity of risk and not involuntarily committing everyone who might possibly be involuntarily committed, but instead finding ways to help people be successful safely in the community at that lowest level of care that's appropriate. In our program, we're built strongly around the ideas of motivational interviewing and dialectical behavior therapy. There's an old joke in mental health. How many psychiatrists does it take to change a light bulb? Only one, but the light bulb has to want to change, right? It's an old joke. It's not a great joke, but I kind of like it. And one of the things that I like about Resolve, one of the things I like about some of the newer crisis programs that are out there is they get the joke. They understand very clearly that we've got to get that person engaged and willing to make the next steps forward in their own life. Because the reality is that involuntary interventions are reserved for only the most ill people. And if we do it right, if we do it effectively, we can help people long before they reach that critical stage of jeopardy. We want to be autonomy oriented, no force first, shared and consumer driven decision making, while at the same time embracing the fact that sometimes that decision making has gotten them to a point in their life which is pretty dangerous and not going very well. So how do we motivate them to take the next steps to make some important changes in their life? a vital part of what we do at Resolve, a vital part of many of these crisis programs across the country, is direct involvement of peer professionals. So these aren't just volunteers who drop by now and then. These are paid staff who have the lived experience of recovery from mental illness or substance use disorder. And they come in, and in our center, they're part of our direct care staff. They were, in fact, part of the design process for our program about sort of what Resolve needed to be. And it can look very differently across different agencies. But it comes back to some important recovery concepts, right? Nothing for us without us. Understanding that we all have different roles to play, but there's something special that a peer can say to a client or a consumer who's in distress that I might not have the credibility to be able to say to them. They might have an opportunity to engage with them in ways that I won't understand or won't be able to. And by the way, one of the things I'm very proud of about our program is we have about 5 times as many peer specialists as we do psychiatrists or nurse practitioners. And I feel that's probably about the right ratio. Well, I wish I could say it was all smooth. We have challenges just like every other program does, right? We have the challenge of really complex territories that we need to cover, where we've got to be really good at the clinical stuff, but also really good at practical problem solving. Ways to capture important pieces of information that we might need to draw on frequently, yet realizing that there's always novelty and there's always something new. And certainly every individual that we work with is unique and their experience is unique. But also there are situations that we encounter all the time that are completely novel. Again, I've been doing this 30 years. And part of the most exhilarating and wonderful part of it is every week I'm sitting back thinking, that's new. That's something I just haven't seen before. You might have heard the old adage that someone's been doing something so long that they've seen everything. I can tell you I've been doing this long enough to know I will never see everything. We've got to know the territory. Who are the other partners and players in our community, the other mental health providers, the emergency department teams, the law enforcement teams. By the way, here in Allegheny County and Pittsburgh, we have over 100 law enforcement more than 100 jurisdictions for municipal and state law enforcement that are operating, not counting the feds, not counting private, university-based law enforcement teams. That makes it really tricky, and there's a lot of people to know. And sometimes you're just not going to know everyone, and it's about maintaining the right posture of making yourself open and available to quickly developing positive relationships. We've got to deal with people with really complex disorders. We have systems that want to say, treat substance use or treat mental illness. Well, it's pretty hard to find someone who's sick enough to need really high-level substance use treatment. That's not also checking the boxes for other types of mental illness, for physical health issues. It's not just dual diagnosis, it's triple and quadruple diagnosis. We have aging populations. We have gaps between the law and where compassion leads us, where you can be really ill and really struggling to function, but not meeting criteria for involuntary treatment. We have disruptors, just like any other place does, trolls and hoaxes and prank calls and denial of service attacks. We have, like most states in the country, 20 years of increasing suicide rates despite our best interventions. We always have the challenge of finding funding and making sure that we're adapting to what our community needs and how we can use that funding appropriately to deliver those services. Now, by the way, the mission statement written for us by our community partners, by our stakeholders, includes being cognizant of the stewardship of public funds. And we get it. There's not a lot of money to spare, right? GDP for healthcare expenditures are 17, 18%. If you have a plan to improve services in your community by going up to 19 or 20%, then you've got some political skills that I'd really like to learn from, because I'm not sure that's going to be very viable in a lot of our settings. We've got to figure out how to be more efficient with less money. Okay, so what really makes it work? What's part of what allows us to do the great work that we're able to do? Well, part of it is the recovery model. Not just because it's trendy, not just because it's the ethical way to go, because damn it, it's just really practical. The traditional medical model often focuses so much on risk factors and stressors that we forget about the protective factors and the strengths. And those are the tools that help us leverage helping people succeed at lower levels of care, right? If we're only focused on diagnoses and symptoms, we miss so much of what drives risk and also the ability to help people get better, that it really hampers us and cripples us and our ability to treat the people that we want to care for. Staffing is critical. We have about 150 positions, right? And we have 150 people working really, really hard in our agency. And part of this is about, being tough on recruitment, but sort of open-minded and bringing people with really diverse backgrounds. Retain the folks that are worth retraining and trying to do right by everyone, knowing that for a lot of folks, this is not the right place to spend the rest of your work life or the rest of your career. We've got to attend to, navigating the currents of funding and public policy. We've got to maintain positive relationships and build positive relationships wherever we can. We've got to be comfortable with risk. And by the way, not everyone's comfortable with risk. And it only takes one really scary near-miss incident, or God forbid, one really bad outcome in the community, and everyone wants to rethink the model. You've got to stick with the model, and you've got to know walking in that there will be risk, and that means sometimes we're going to have great outcomes, and sometimes it ain't going to be perfect. We ask a lot of our staff. We put so much on our shoulders. We're always looking for ways to find how we can help them continue to have the strength and the focus and the self-care to get through it, not just their days at work, but their lives outside of work as well. And a really big part of this is bringing in partners, executive champions, partners in the community, consumers who've had great experiences, who are willing to go out and say, hey, this is a great program. Many of you have heard about the sequential intercept model. It's a wonderful model that's been around for about 15 years. And it basically says at all the different stages of law enforcement intervention, do we have good opportunities to shift someone from that criminal justice intervention over to the behavioral health intervention, right? So if it's 9 o'clock and the library wants to close and there's someone who really doesn't want to go out onto that cold street tonight, they're kind of balking and leaving. Well, it's a defiant trespass, and you can call police, and they can bring them down and book them. And if they don't have priors or outstanding warrants or something like that, well, guess what? They're now homeless in a new part of the city than when they were before. Maybe that's a good time to call a crisis team, to engage with that person, to get them to some short-term crisis residential supports, try to figure out what's driving that homelessness issue, and try to get them into better services. Right? Finding opportunities all along that sequence from the time police might be called, through arrest, through incarceration, through judicial decision-making, through return to community, and sort of safe landings as people leave the system. How do we make sure that the folks with the mental health needs are getting the right type of resources and services that they might need to really succeed in the community? Okay, and that's a really great model. But now here we are, like 15 years later, and I suggest more and more I think of this as the new sequential intercept model 2.0, like the next stage of it is, we really do want to make sure that we're getting the behavioral health folks over to the behavioral health system, and the mostly criminal justice folks into the criminal justice system. Because, the behavioral health system's really going to struggle to help someone when they've got mostly criminal justice needs and not a lot of behavioral health needs, and vice versa. But now we've got to think about integration, because what we're recognizing is that a lot of the service utilization, maybe misutilization, that happens both on the law enforcement and the behavioral health side isn't by people who just have criminal justice issues in the behavioral health system, but they've got a lot of criminal justice stuff and they've got a lot of behavioral health stuff. And they are a challenge for all the systems to manage. And so we've got to find a better way to integrate and synergize across those silos. Okay? Now, I would also suggest that one of the things that really helps us get through these crisis intervention programs, to make them work, to make them successful, both at the ground level as well as the organizational and the community level, is by having thoughtfully, intentionally diverse teams. Okay, as I said before, there is quite bluntly a problem with white supremacy and emergency mental health, and by that I do not mean that there are people in mental health who have overtly racist views, but it is an implicitly biased system, and we have really unambiguous data to back that up, and it has a big impact for a person who's in crisis. When they're thinking about, how do I reach out for support? Will they understand me? Will they get me? Will they know what I'm afraid of and what I need help with? And it's important that we have not just sort of diverse frontline teams, but diverse teams throughout our entire systems that address these issues. The different perspectives aid us in evaluation. They increase the likelihood of direct engagement. The very backgrounds mean that they'll have different networks, increased resources, increased tools to bring to bear to help people get through their crises. The They help us make better decisions. We have wonderful research that says, small, well-designed, diverse teams, you get to far better decisions than homogeneous teams or individuals. And all of this means that we can come up with better interventions. And that also means knowing that sometimes bad stuff's going to happen. It means that if we're doing it right, that one really bad incident might not wipe out my whole team at a psychological level. Because again, we've got that diversity. And that diversity means our professional background, our clinical orientations, whether or not we have lived experience with mental illness, the color of our skin, our religion, how we fall in love with other people, and so forth. There's real value and there's real strength that if we do it right, if we build those teams properly, it helps us deliver better services in the short term and the long term. I hope I've given you a couple good ideas to think about. I'm actually about to join you live for some more conversation, some more discussion. But in the meantime, I want to do a quick plug for my own organization, the American Association for Emergency Psychiatry, where we've got a broad and diverse group of emergency mental health professionals from across the country who are not coming together in Las Vegas later on this week because, COVID, and that would be a terrible idea. But we are getting together online, and we're happy to have people from all sorts of backgrounds, including administrators, come and join us, for our group, for our mission, for our shared goals of helping our communities. If you have any questions, if you want a copy of the slides, again, we're about to do a discussion, but here's all of my contact information, including my email. If you're on Twitter, please do feel free to follow me at Violence Wonks, where I tweet about violence-related policy issues. Thank you very much.
Thank you so much, Dr. Rosa. We're so pleased and honored to have you joining us here today. We invite our listeners to put questions in the chat. We have a few waiting for us. I have one that I want to kick off with. Actually, I have two. And one of them is related to the questions coming in from our chat. I love your story about the old psychiatrist joke about the light bulb, and the light bulb really has to want to change. And my question upon hearing that is, how do we make the systems want to change? People are asking us, how do we get the agencies to work together, about how do we get law enforcement on board? So would you address that just a little bit, please?
Yeah, so I guess let's take a evolutionary or biological approach to this. There is slow, gradual evolution, small nudges, small changes to the system over time. We test, we wood chop, we say, okay, we did this intervention over in county number 1, and we got these results. Let's tweak it for county number 2, see if we can get it any better, and get this sort of gradual, slow progression. And then, and that's one way that evolution works. That's one way that systems grow, one way that change happens. It's slow. I was chatting with a friend recently about how, you're banging your head against the brick wall. And I'm convinced that sooner or later that brick wall will yield. But in the process, I'm going to have a little bit of a headache, getting there. Here's the other approach. Sometimes the comet hits. Sometimes there are catastrophic, horrible events. And one of the mantras we come back to over and over in our field is never let a good crisis go to waste. Now, don't let crises happen if you can possibly avoid them. But sometimes, despite our very best effort, something happens, something really bad happens. All of a sudden, your town, your county, your city is trending on Twitter, and not in a good way. And it's every hand on deck to take care of your community and your people. And that's when there might be the political motivation to say, oh, wait, we don't just need to make a small nudge in the system. We can, this is where we actually have the political will and maybe the resources and the opportunity to say, let's make these huge, large changes. Now, by the way, not to be reactive, not to respond to N-of-1 events like they're a general trend or sort of describe the territory well, but to say, you know what, we've been recognizing that there's this growing set of discrepancies between what we set up as our policies and our regs and our systems and what our community needs, what our patients and their families need. And we've understood that disparity better and better. And now we've got an opportunity to make a leap to be where our communities need us to be. Right. So, over, over on my desk, I have a folder. It says fire sale, as in everything must go. So, what are the 5 or 10 high priority items that I'm pushing on every time I talk to one of you in the government or regulatory field, but I also have ready to go when people are really ready to move. Does that make sense?
That makes lots of sense. And it ties into what your comment, the next question ties into your comment about never letting a good crisis go to waste. It's about how do you see CIT fitting into this? And as we know from the history of CIT, that was born out of crisis, about injuries and deaths to mental health folks in mental health crisis, and injuries and deaths to officers. So how do you see that fitting in?
Yeah, so I think CIT is a wonderful model, a wonderful intervention. In Pittsburgh and the Allegheny County area, we are really well resourced. We have our program, which obviously I'm a big fan of. We have some great psychiatric ERs. We have wonderful community services, ACT programs. We are kind of rich in resources. And yet still, when a family or a person is in crisis and you need somebody there right away, it's almost certainly going to be law enforcement. We've worked really hard in our region to do CIT training and to develop the team, which is the real T of CIT's teams, not just the training, so that we have those networks in place. We've trained several hundred officers over the past decade. I've had the privilege and honor to actually be part of that training. I've worked with almost every trainee who's gone through over almost 11 years now. It has a critical role. And I think any community that might have it should have it. I think of CIT as sort of the gold standard of our best officers, our most motivated officers, but also maybe at a minimal threshold level, I think all officers should be getting something like mental health first aid or something, about how to recognize a person in crisis, how to work with someone, how to de-escalate them, how to say, aha, this is, someone at risk for suicide. Aha, this is psychosis. How to figure out, how to get someone through a conflict or a crisis without tackle and shackle, handcuffs and an arrest, but to think about, hey, what about all this behavioral health stuff? And by the way, I get it. Cops have so much on the things that our communities expect of them. And it's really tough to say, hey, we also need you to be mental health professionals. And I love the idea of having lots of mental health professionals there and ready to go. But the reality is that for most of our country, that's just not practical. And there's always going to be situations where we need the cops and we need the mental health professionals, because there's some things that I just can't fix with a social worker or a clinician, no matter how good they are.
Thank you. One of our participants would like to hear you talk a little bit about how crisis intervention, the way it is and the way we'd like it to be and the way it is at the Resolve Center, about how that sometimes results in involuntary commitments.
Yeah. So in my rosy glassed world, good, accessible, engaging outpatient care will help the vast majority of folks. And by the way, I think a lot of the crisis of inadequate inpatient psychiatric beds is a lot about inadequate outpatient services that would keep people from being sick enough to need those inpatient beds. But yeah, here's the thing, even with the best systems, mental illnesses can suck and they can be terrible. And they don't just make us ill, but they distort our view of reality and our view of ourselves. And sometimes people will be so ill and so dangerous that we've got to do that involuntary intervention. It's I went to med school and I learned about how to treat psychiatric illness. I went to law school and I learned about civil rights and the legal system and due process. And I think if we do it right, these weave together incredibly well. But there is that gap where someone is so ill and so impaired that objectively, externally, we will consider that person is really suffering. And either they don't recognize that they're suffering, or like, you know what, I want to be this way. And we look at it, and it pulls at our heart. It is within their rights, and it's reconciling that gray area is really tricky. Reconciling what to do when we know someone is on that course to be dangerous towards themselves or someone else, but they haven't quite done that act of furtherance or something else. It's a really tricky space to manage.
We're getting close to time, but I think it's really important to talk about the role of peer specialists at the Resolve Center. We had a question early on about how many peers are on staff, and if you would tell us a little bit, please, about their roles.
Yeah, so we have about 15 peer positions, and it's tricky, and this is the dirty truth. Being a peer professional has a glass ceiling effect. We have tremendous, skilled, awesome, amazing peers across our program, and they can only go sort of so high in a peer position. A lot of them transition to clinician roles. It's one of my favorite things is watching them get into grad school and everything else and sort of advancing their careers. That's one of the things I really love. But the reality is in that peer special, they're kind of limited. They greet people as they arrive. They work with them intensely in the milieu. They help with our follow-up calls through the phone center. I used to work in New York. We actually had a parent peer advocate engage with our mobile team, which is a wonderful, wonderful intervention. There's so many great ways to use peers. And by the way, to be clear, our newest data says that mental illness doesn't impact 1 in 5 of us or 1 in 4 of us, but about 5 out of 6 of us, right? We are all peer. But our peer specialists have some special training and some special resources, and they're in that very special role that they're there to use their experience as part of their intervention in a way that many of us who are, prosumers or whatever other term you want to use, that we're not able to use that lived experience. So they're an incredibly valuable part of our program. And by the way, they are staff. They are paid. They go through all the same kind of training, mandatory, annual education, blah, 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 as anyone else. They're not volunteers. So nothing wrong with volunteers, but ours are staff.
Well, thank you. That peer roles are very important to Mental Health America. As you know, in fact, we have a national certification so that peers, no matter how they're trained in their states, can show they have a level of competence. We hope this will raise the pay level of peers, because we want to see peers paid what they are worth, which many times they are not these days. Absolutely. And also will give them the ability to work across state lines. So we really appreciate everything that Resolve is doing with respect to peers and having peers be important parts. It was always my pleasure when I was in Pennsylvania to have many, many peers as staff members, peers in all of the psychiatric emergency rooms that we oversaw in the city of Philadelphia crisis center. So we hope that more and more municipalities, states, hospital systems, crisis centers will, of course, include peers. A lot of people have been asking questions that I'm going to defer to our next speaker, who is all about CIT, and she can really talk about that in great depth. But what would you see as the kind of overarching pulling together, getting that message to the dispatchers, to the people who take the calls? We know we're about to have 988 come in. So how do you see that all coming together before we move on? And I'll need you to be pretty brief about that, because I have to introduce our next speaker too.
Hopefully smoothly. So the best crisis team in the world can't do much of anything if they're sitting in the office waiting to be called. And right now, most 911 centers prioritize and they say, which of my emergency services, police, fire, medic, does this caller need? And if it doesn't clearly fit into one of those buckets, then maybe they'll think about calling local mobile crisis services if they are lucky enough to have those. But oftentimes it's a sort of a triage by elimination. And maybe we have an opportunity now with the current dialogue, again, never let a crisis go to waste, to rethink some of that in a way that when can we safely and appropriately prioritize and bump up and make accessible those types of mobile crisis resources. And I think 988 is going to open up sort of, vast new territory. We're going to need all of you to help us at the state-by-state level to create the funding streams and the structures to pay for those mobile crisis services, because we also don't want to be in the situation of taking calls as, gee, you sound like you're in a terrible crisis and we got nothing for you, right? We want to be able to get those services to the people and the family needs. So,
well, thank you. Dr. Roselle, we're so honored to have you join us today. We look forward to lots of collaboration with you as we move forward. And with your permission, we'll call on you again for your great expertise and enthusiasm and way of really making these issues come to light. So thank you again.
It's been a delight. And again, my contact information is in the slides. Please don't hesitate to reach out if I can ever be of service to you or your community. So thank you and stay safe.
Thank you, Jack. Yeah. It's my pleasure now to introduce Carol Ballard. And Carol is really the expert on CIT. She's the Director of Education and Training on the, I'm not sure what all these letters stand for, the ADAMS Board of Cuyahoga County, Ohio. And we know her through her exemplary work as a board member of CIT International. And she's been training with CIT for many, many years. And she has coordinated the systems in Cuyahoga County, Ohio. And she has an amazing perspective from her many years as a social worker, as a trainer, as a CIT coordinator. So I hope you'll all sit back with me and listen as Ms. Ballard shares with us her perspective from how we got to where we are now, where we've been, and some places we can move forward. And she'll be with us to answer some questions, and I'll direct some of the CIT questions that have come in already at the conclusion. So I'd like to introduce Dr. Carol Ballard.
Good afternoon. My name is Carol Ballard. I'm the Director of Education and Training for the Alcohol, Drug Addiction, and Mental Health Services Board of Cuyahoga County. Cuyahoga County is located in Cleveland, Ohio, and we are the largest ADAMS board in the state of Ohio. An ADAMS board is the behavioral health funder for drug addiction and mental health. We serve adults, youth, and the elderly, serving somewhere around 30 to 35,000 people per year. But today I'm going to be talking to you as the CIT coordinator from Cuyahoga County, as well as being a member of CIT International Board of Directors. The CIT International Board is the founding body for crisis intervention team training, programming, policies, practices, and procedures. It's an 18-member board, and we've been CIT International for at least 20 years or so. CIT in and of itself is around 33 years old, although in terms of programming, although a lot of times we hear about CIT in more current, recent events as new programming, but it's actually fairly dated. CIT actually started in 1987 following a series of concerns in Memphis, Tennessee. In collaboration with the National Alliance on Mental Illness in Memphis and the Memphis Police Department, along with the University of Memphis, they created what we call CIT training, Crisis Intervention Team Training. This is a 40-hour training developed to raise the awareness among law enforcement regarding mental health related issues, concerns, giving officers that sense of awareness, creating a week of interactive and didactic opportunities, going with case managers on ride-alongs, spending a lot of time listening and talking with people with mental illness, and embracing mental health and recovery-related issues. The hallmark of CIT is communication and de-escalation training. And I say all of this because it started 32 years ago, as a remedy to helping law enforcement engage people in crisis. These officers became special officers for special people. So let's think about what happened 33 years ago. Deinstitutionalization of the mentally ill across the country. Many of these consumers were coming out of long-term hospitals. into communities that weren't quite ready for their return. They lacked the structure, they lacked housing, they lacked family, friends, and those in the community. More importantly, they lacked income. And what evolved from there were specialized initiatives, specialized programs funded by federal, state, and local authorities as a way to support the mentally ill reintegrating into the community. But with this came some unanticipated consequences. Many of these programs to help the mentally ill who might be involved with law enforcement because they were lost, because they were homeless, because they were untreated, came to the attention of law enforcement, many of whom may not have received CIT training. And as a result, many of this population were charged under the criminal code. They were sent to jails, sent to prisons. And our jails and prisons became the de facto mental health hospitals. Because in Ohio, 30 some odd years ago, we had 12 institutions. And in 2021, we now have 4. So that meant the people that we were taking care of in those institutions were now living in the community, now engaged with criminal justice, now on special units in our jails, special pods in our prisons, oftentimes staying longer than those without a mental health issue. The minute they came into criminal justice through jails and prisons, their Medicaid was cut off. Their Social Security was cut off. They lost their housing, they lost their family, and they lost that stability. Good intentions for specialized unit to give special attention, but with unanticipated consequences. Then came the wave of specialized programming and specialty court dockets. But these specialized programs and dockets were all dependent upon arrest. They were not voluntary programs. So officers, as they engaged the mentally ill and took them to jail, these folks were screened into specialty docket programs for mental health, for recovery court, for veterans court, all at the hands of police. Then came specialized probation units and specialized parole units called FACT units. In Cuyahoga County, we've experienced it all. And the one caveat that we do know is that our system, our behavioral health system, was solely dependent upon law enforcement as that first responder, as that source of referral, as that source of gathering. If a person was on probation and on the specialized docket, the habeas was issued and the police went out to get these people, creating an adversarial and sometimes controversial relationship in the community. This is where specialized officers called CIT started to engage even more specialized people. Nationally, we know that every 10th call across the country involves a person in crisis with mental health. And in most cases, these are going to be high utilizers of service and people that many of us in behavioral health know. But behavioral health changed since I was first involved in behavioral health some 40 years ago. Behavioral health has become more office-bound, with 15-minute interval appointments, with high caseload, 60 to 75, with very little outreach due to volume, due to productivity, due to a number of different circumstances. And so as behavioral health specialists, mental health workers, we relied upon police to do some of the work that we used to do. When I started in behavioral health, we did something called outreach. It was old school grassroots outreach, where you actually knocked on the person's door. We didn't send a letter, we went. We didn't call the police, we went. But that's a little different now, because now we have other issues. We have less workers coming into the system. We have productivity standards where a certain amount of time has to be spent in documentation. We have clients who are much more transient or viewed as being transient. And we also have difficulties navigating our own system at times. And so we solely relied upon police. The other complication that we found, and it's an unanticipated consequence, our federal and state grants required a partnership with law enforcement. Well, that's a unique partnership with law enforcement, public safety, and others, and we welcomed it. But that partnership was dependent upon law enforcement doing what they do best, community work. That was the work that we were doing. In order for some of the programs to actually operate, like a program that we have in our community, police had to be the source of referral in order to divert that person, not us. So that involved police engaging somebody in crisis that we knew, but in order to get them into that program, we had to allow police to be that first responder. When you start to look at the position that we put police in and the emergence of the CIT program and the encouragement across the country that every department have a CIT officer throughout all of its shifts, one tends to wonder what happened to mental health. Where were the mental health workers going? Mental health waited because now they had a new ally called law enforcement, called CIT. Well, that day, that time, and that moment started to change. Because even with all of the training that we've done over the years in CIT, all of the discussions and partnerships and projects that we've had, because many of you have those programs in your community. You have mental health courts. You have specialized probation units. You have all of these resources out there as well as we do in Cleveland. But you have unanticipated consequences because it involved police doing policing work. Some in our community say police are being more social workers than we are. We're asking police to wear polos. We're asking them to wear patches and sashes every day instead of their uniform. We're asking police to drive an unmarked car. We're asking police to partner with us to go out and do outreach on our calls. We've been asking them to change how they police this special population, and they have responded across the country. Numerous initiatives, co-responder teams are emerging in just about every state in the nation. Unique opportunities where law enforcement will respond to that social worker if they're out there. But in doing so, the people are reacting to the men and women in uniform. And sometimes that presence can escalate that crisis that's already out of control. In many cases, we already knew that when we called the police in the first place. Even when you look at models, our intention was that these models, these special areas, were there to help get that person get relinked to services. But in many cases, it wasn't just that one referral that was going to do it. It's going to be numerous opportunities that we would have to engage that person in crisis. And so we waited. We knew that we would see that person eventually in the ER. We would see that person eventually in the jail through the jail liaison. We would see that person eventually in prison coming out on a forensic assertive community treatment team. The problem with that is we might have criminalized the very people that we were there to help. Because in order to access these high intense evidence-based practices and services, they had to be arrested first. We created a criminal record which enabled them to be unemployed a lot or unemployable because they had a felony offense. In a traditional drug court model, those that participated at the municipal level had their cases nullied. So therefore, they didn't necessarily have a record once they completed the court. But mental health court dockets typically are much longer than drug court dockets. And those cases aren't going to be nullied. That's part of who Jane Smith may be, because they were involved with the criminal court. That impacts their employment, that impacts their housing, that impacts a number of things that they may want to do later on in life. So it's a little different. And so how do we turn the clock back? In CIT International, we've been talking to law enforcement departments across the country. When George Floyd, the scenario of George Floyd, Breonna Taylor, and others, Daniel Pride, and others emerged, law enforcement departments started saying, we are not the first responders. We don't have all of the skills, the knowledge of being a social worker. We've taken some training. We've developed some skill and expertise. We know how to manage some of these calls, but not all of these calls. And some of these calls could be responded to by mental health. Enter the CAHOOTS model. And most of us are familiar with CAHOOTS. They got a national reputation throughout this COVID-19 because of their ability to respond. But more importantly, they've been the talk within the last several months at a much higher and more intense level because they are a non-law enforcement response. Mental health workers with EMTs responding to people in crisis, saving almost $15 million over the period of several years because they are responding to those high utilizers. They are responding to those folks in crisis who they already know, leaving the cases for CIT officers of those that we don't know, of those that may have the potential for risk, of those who may have the potential for other things that might be going on. The more complex situations that law enforcement response with a CIT officer may best be able to respond to. Law enforcement agencies have come together and they're repeatedly talking about non-law enforcement responses. Today in the news, we're looking more at what's happening in Los Angeles, Denver, Chicago, New York. They're all talking about the same thing, non-law enforcement responses. Mental health workers paired with peer support, paired with EMTs, paired with others to respond to certain elements of people in crisis. Look how far we have come. Our initial response was law enforcement only. And then when law enforcement responded, we created specialized dockets, specialized programs in order to transition these folks from criminal justice into the behavioral health system, not realizing that it took them longer with huge losses to their personal lives to go through that process. Then we saw the emergence of CIT programs across the country, but CIT officers said, we seem to be engaging with the same people and we're doing the follow-up. And so now we're back to the grassroots of what I was familiar with. When I became a social worker in 1984, our job was to respond. We worked non-traditional hours. We worked in the community. My first experience was with Traveler's Aid. Some of you out there may not even know what that is. Traveler's Aid was one of the first national crisis response models in this country. Crisis workers were housed at Greyhound bus stations. They were housed at the airport to encounter people in crisis. Because guess what? That's how they got out of mental institutions. That's how we found a lot of missing persons. That's how we dealt with juveniles and others in crisis. They were coming through transportation means. We had workers scheduled who were on duty at various hours in order to capture people in crisis and re-engage people and get them connected to resources in the community, and to do the follow-up. The follow-up became the most important part of anything that we ever did. We can make a referral, but we didn't know if people got there unless we followed up, and keep following up until it becomes a habit and a need for that person. Because mental health, although there is no specific cure, what we do know is that people recover. People want to get better. They just need help on how to get better. And we can do that through our own follow-up, our own support, our own guidance, our own listening, and the emergence of peer support. Who best can respond to people in crisis other than peer support? Engaged in a two-pronged process, we could be dynamite in the community. That was the community that I used to know. That was the community that I started in some 40 years ago. I wasn't familiar with telehealth. I wasn't familiar with appointments every 15 minutes. I wasn't familiar with the 9 to 5 because I was assigned to the Greyhound bus station, and transportation is 24 hours a day. And guess what? It didn't happen between 9 and 5. So now our country, across the country, law enforcement departments are talking more about non-law enforcement responses. In sequential intercept mapping process, they describe and define law enforcement as ground zero. But ground zero is probably our crisis system. Because if our crisis system fails to engage that person in crisis, then the next response may be law enforcement instead of the other way around. Why invite them to the jail when in fact we could divert them ourselves, because they don't need to go to jail? We know who they are. We know what their issue is. We can create community plans. We can create system responses to some of these folks in crisis. They say that even in our community, 20% of those calls involve the 80% of those calls involve the same 20% of those people. Officers know who they are, know where they live, know what the story is. We should know the same thing. Because if we responded to those folks, can we reduce that number? Cahoots has shown us that they can in their own data. These new programs coming through Los Angeles and some of the larger cities are going to provide that data to us as well. At CIT International, we've talked a lot with our partners and stakeholders out there who have said, we need a different kind of support. We need to support and advocate for mental health, particularly behavioral health, to get the funding that they need to re-engage the community. And I use the words re-engaged because we've gotten out of the practice of it. I've heard directors actually say that they've actually gotten out of the practice of it. So just like we created crisis intervention team training, which is a 40-hour training, it's voluntary for special officers, for special people, as per Lieutenant Woody here in Ohio. We can create some kind of model for training, policy, practice, and procedure for behavioral health in order to re-engage the community. Because when we do that, we would be teaching them about community, communication, and de-escalation. How do you de-escalate somebody without a gun and a badge? Visiting nurse groups and others like that do it every single day. They re-engage people every single day because all of their work is in the community. Traditional ACT team models is the hospital without walls. They engage people in the community. So creating this avenue for those persons in crisis by our crisis specialists in the community is that non-law enforcement response that law enforcement and others want to see. Our federal government, hopefully, once we know, is probably in that same path, because we've heard it come from the federal government itself, that maybe we're putting too much into the basket of law enforcement. CIT in and of itself will still be with us, because we need special officers for special people when the crisis system is not able to contain or manage the situation. But in that partnership, we will be learning more about our capabilities, because we are solely capable of managing some of these calls. And there are some areas that we may not be able to engage at all. But through that unique partnership, that's where we need our crisis intervention team officers. I hope that this is helpful to you in thinking through where we are today, because we had the best intentions by creating programs and services for mentally ill involved with criminal justice. The problem was the unanticipated consequences, the unique burden on our jails, prisons, courts, but more importantly, what happened to our family members, consumers, and others when they engage law enforcement. In our country, we've seen a steady rise in cases, national cases, that involved encounters with law enforcement. And that's what brought this conversation to us. George Floyd, Daniel Prude, you name it. There are cases in each of your community where you say, well, yes, that involved a mental health person. But it didn't have to be that way. Because as a lifetime social worker, licensed independent social worker, I know from the social work community, we're here and we want to engage people in crisis. We want to help people in the community, and we want to work in a collaboration, and we need to get ourselves back to where we started. Because in the history, the very origin of social work, we were in the community. That's how most of us learned about working with families and others. We didn't learn in an office. We didn't learn in a 3-story building. We learned on the steps of Mrs. Smith's house. We learned how to address her before the crisis came. And we also didn't rely upon sending her a letter. We came back the next day to engage that family, because every time we did, that ensured better outcome for that family and that community. So in my discussion today, I wanted to bring us back to where I was as a social worker some 40 years ago. Get familiar with our community. Create that dialogue in your community. Talk about what you may need in your behavioral health system in order to create non-law enforcement responses. Nothing is impossible. Many of us as social workers are involved in CIT training as trainers. Train our community. Use those same skills that you have in training law enforcement and train our community of social workers, counselors, and behavioral health therapists and peer support on how to engage people in crisis, because that is our last stand. That's how we turn it around. That's how we reduce the costs in the community. That's how we bring back dignity to our profession. And that's how we become partners, true partners to law enforcement. Thank you very much. Thanks for listening.
Thank you so much, Ms. Ballard. We're really thrilled to have you joining us today. It's Mental Health America, a great honor to work with CIT International. And what you had to tell us today was so important about the lengths we have come, how things changed, and where we need to go. And that really includes getting back to two of our most important concepts, and that's engagement and how to do outreach. And it's so important for us working with CIT International to be able to show that CIT is important, and its 35 plus year history has taught us a lot. You raised some incredibly important points about policy and good intentions, and how when we know that it's important to train officers, we then made it mandatory through grant programs that the federal government did, that started mental health courts, that ensured that police are part of the equation. And we know that's not going away soon. Questions from the folks who are listening today, coming through our chat, include things like, tell us about how, if you think that every officer in a department should be CIT trained.
That's always a controversial question. It really depends upon the size of that department. So in small rural areas, you may have a department of less than 25 officers, which means that that department will probably train all of its officers because they're all going to be identified on various shifts. But when you get into larger departments, the rule of thumb is to train 20 to 25% of those basic patrol officers. And the rationale for that is that you want them to be voluntary. You want them to have a couple of years of experience. You want them to understand that they're going to gain a lot of experience in responding to these calls. Not all officers are CIT officers. And when you train every officer in that department that goes beyond the threshold of a 25-man or woman force, then you've changed and dissolved, watered down that approach. You're no longer following that fidelity to model. You're using some other formula, and it's much more unpredictable to you when you train everyone. So that's been the stance of CIT International from day one, up to 20 to 25% of basic patrol.
We truly appreciate that. When I was in Philadelphia, part of the team that helped bring CIT to Philadelphia, it was clear that what made the program so successful was the officers volunteered for CIT training. They had a specific interest. And almost always, for most of us in behavioral health, and as Dr. Roselle said earlier, well, 5 out of 6 of us for mental health, it's personal. It is personal, and it really to have that experience. I want to shift gears a little bit and talk about what the data is showing these days with respect to inequities and racial disparities, and how some communities are particularly uncomfortable when it comes to having officers be that first responder.
Well, and I think you raise a good point. Like any other profession, most people are comfortable with people that look like them. There's going to be a trust level that comes almost automatically, because the person in crisis is going to believe that you understand my story. You're not judging my story, you understand my story. But there are those who may not look like me, but really do embrace my story. I wouldn't say that they're far and in between, but they are out there. But the general rule of thumb, and what we've seen across the country, is that communities are calling for more officers who represent the Black and Brown community. And this is a challenge across the country, because you have to find those special people to come into public service. come into a world where the general community around them doesn't like police officers, don't like what they stand for. When they hear a story on TV, they're all alike. They're stereotyped, they're stigmatized. They are probably the least popular profession that people want to go in, but the most important profession that people should consider, because public service is where we need to be. They are on the ground and they give us a lot of momentum. But yes, it begins the social inequities. When I think about it, the people that responded to us in crisis were also the people that arrested us in crisis as well. So it created that upside and that intimidation factor and fear factor. And that's never going to go away because it's a lived experience that's unique to Black and brown people. And we all have a story to tell.
Thank you so much for sharing. This is a subject that is so important for us to talk about, to listening to people, to helping people get what they want, what they need, when they need it, and from whom they feel comfortable receiving it. Again, one of the important things that as we look at CIT's role in crisis, and we look at peers, and we look at peer specialists as well. We know having that lived experience matters, but also having people that look like the people they're responding to matters as well. So we think that that is extraordinarily important. Carol, before we go, would you talk just a little bit about how CIT International is working to get the types of systems change we've talked about? We'll hear from the Denver STAR program in a little bit, and they follow the CAHOOTS model as well. But can you talk about how CIT is helping bring about the systems change while holding to the fidelity of the CIT model, please?
Well, what we've done a lot in the last several months, in the last year or so, we've tried to partner with our stakeholders, the International Police Chiefs Association, different groups, law enforcement groups like that, who are talking about how do we turn this around a little bit. And I think that we have created position papers and white papers regarding the philosophy. And it's not a philosophical change. What it is actually is an expansion on what we already know. And we know that we cannot resolve all crises in the community. And so we need the partnership of behavioral health, but at different levels, so that we are not solely, or the community is not solely reliant upon law enforcement. So we've networked and partnered with federal and state officials to create that platform so that we can talk about that more readily. In our CIT International Conference, there will probably be numerous opportunities where different programs like STAR and CAHOOTS and others will be talking about those experiences. That's something that we want to encourage, so that the communities around us will start to learn it is possible to engage people in crisis. And so as we go in, oh, I'm sorry, go ahead.
No, I apologize. We are going to have to move on in a minute, but with your permission, I'd like to share those white papers with our participants.
Okay.
So we can, if it's okay, we'll link them to the recording here today. And we so appreciate you being with us. Again, thank you, Ms. Ballard. Thank you to CIT International, and Mental Health America looks forward to continued partnership. Again, thank you.
Thank you.
Bye-bye. You're most welcome. Bye. We're going to shift a little bit to talk about the other side of police, not just how police come out into the community, but we're going to be joined by Mary Van Hout. And she has 30 years of experience in education. And a great deal of that education is working with officers, families, working in suicide prevention. So without further ado, I'm pleased to introduce Mary Van Hout.
Thank you, Debbie, for the invitation to be part of the Regional Policy Council meeting. It's an honor and privilege to be included. Special thanks to Paul Gianfrido of Mental Health America, who connected me with Debbie, and thank you all for participating in the meeting. 3 focal points. I share perspectives on a motto in law enforcement: to serve and protect. Because law enforcement agencies hire from this group we call the human race, that mantra will have limitations. Full disclosure, I am not in law enforcement, nor an educator in law enforcement, never have been, never will, as I cannot do the job. However, I am an ally, an advocate. Born and raised in a legacy fire service family, I married into the law enforcement profession 42 years ago. That introduced me to the stark reality that public safety professions cannot be lumped together. They have unique stressors and protective factors. They have distinct differences in the way the public perceives them on and off the job. Also, I am not a psychologist or sociologist. I'm simply an ally and a voice for a group of people in great need of mental health services. A group of people who often remain reticent rather than advocate for themselves or for each other, even reticent unto death by suicide. Through my lens of lived experience as a family member, a survivor of suicide loss, and a trainer, I hope to challenge some common perceptions and provoke innovative ways to intersect the philosophy of Before Stage 4 and the motto to protect and serve. A close examination of police procedures and policies is a necessary, warranted part of the hard work of justice. The cost of being passive or patronizing is just too high. This is not the first time our nation has been jolted into action, yet past mandates or legislation for reformative justice has failed. To get something different, we must do something different. Many law enforcement agencies and communities have made great strides to build healthy relationships. Yet we've seen how vulnerable and how tenuous that progress is when there are past grievances, bias, and pain embedded in a community or a culture. To put that in perspective, let's take a look at the first focal point, the history of law enforcement in the US. Here is a highly condensed version readily available through research. Earliest forms of American law enforcement appeared in the Northeast. They were volunteers in watch systems that warned of impending danger. The first formalized tax-funded police department started in Boston in 1838. Shipping companies needing protection of their properties and the harbor wanted to transfer the cost from their business expenses onto the citizens of Boston. In the southern states, American policing followed a much different path. They also established a system to protect the wealth and property of the upper class. However, property included people. The first formal slave patrol was created in the Carolina colonies in 1704. The patrols had 3 primary purposes, including to deter revolts through organized terror. Following the Civil War, police departments in larger southern cities were an outgrowth of these patrols, enforcing Jim Crow laws and ensuring that African Americans stayed in an agricultural caste system without a voice in political or social issues. By the end of the 19th century, municipal police departments emerged as a response to disorder rather than crime. What constitutes disorder then and now depends largely on who defines disorder. It's obvious economics and the wealthy class were the impetus for a system of enforcing laws, but the oppressed demanded reform via local government investigative commissions. At the federal level, the first government body to investigate law enforcement was the Wickersham Commission of 1929. It addressed rising crime in the country and law enforcement's lack of response to the crime during Prohibition. In the mid-20th century, police departments underwent internal reform, creating professionalism, expectations of leadership, educational requirements for recruiting and promotion, and mandatory trainings overseen by state standards bureaus were part of this shift during a more peaceful time in our nation. By the end of the 1960s, though, a perfect storm was brewing. The Great Migration from the South was met with redlining. Blacks were denied basic rights of housing and jobs. Where they did find housing and employment, there was fear and white flight. Anti-war, anti-government sentiment grew, along with the rise of illicit drugs. During this time, President Johnson created the Kerner Commission. Searching for the genesis of rioting in large urban Black neighborhoods, the president hoped that the commission's findings would mirror the McCone Commission report on the 1965 Watts riots. That report stated the cause of the civil unrest was rooted in the residents themselves. The Kerner Commission was in complete contrast. It implicated white society for the creation, maintenance, and perpetuation of the, quote, ghettos. The report warned of a pending divide in the U.S. that would fracture into two radically unequal sides. Offenses were taken, tensions rose. Once again, law enforcement was called upon to meet political and social expectations. They were called upon to fight the war on drugs and to control disorder. Actions that only reinforced implicit bias among law enforcement and with underserved, oppressed people of color. This was 50 years ago. In 1963, the Los Angeles City Council passed an ordinance to adopt the motto, "To protect and serve," as the official credo of the department to express the ideals and dedication of the LAPD. It has been adopted by many police departments across the nation, evidence of the cultural change within police agencies that was slowly evolving in the 20th century. Prior to this, the emphasis was on protection. Now more emphasis was placed on service. There was a cultural shift emphasizing the human element in policing for both the people they serve and the officers. Yet, as evidenced by President Obama's task force on 21st century policing, these changes are still works in progress. The task force was charged to, quote, identify best policing practices and offer recommendations on how those practices can promote effective crime reduction while building public trust, end quote. The May 2015 report exemplifies a further shift in police culture, though. It was the first report to make recommendations on ensuring the mental wellness of officers as a means to strengthen police and the communities they serve. Another sign of a transition to the human element of policing. The chasm of social divide in our nation today requires law enforcement to diligently and delicately balance protecting and serving. It is the right of all people to live in a safe community where laws are enforced equitably without bias. With public discord and divisiveness in our country, it can be difficult to meet the expectations of every person they serve. That's an arduous task that weighs heavily on the minds of those considering the profession, and it negatively impacts the mental health of those in the profession. A reminder, officers are people, humans worthy of and entitled to services that keep them physically and mentally healthy. Reflecting on the before stage 4 philosophy of MHA, we cannot ignore symptoms or risk factors for depression and suicide among this population. If we ignore them, we lose productive lives, diminish opportunities for recovery, deplete support systems, and accentuate a path to unhealthy living. A specific example within law enforcement would be the danger of uncontrolled skepticism. Skepticism is a necessary component to their work, but when skepticism starts slipping into cynicism, it could be a symptom of deteriorating mental health in an officer, and intervention can take place. Moving into the second focal point of my presentation, let me share some examples of the factors that elevate risk of poor mental health or suicide in a law enforcement officer. First of all, their personal attributes. They're risk takers. This is not to be confused with being power hungry or reckless. Because they are risk takers, they would be in a position to use power and authority if necessary. That does not give them a right to abuse power, be reckless, or lawless. They have overexposure to trauma, not just acute and momentary, but chronic and pervasive. They become inured to death and dying because they're regularly exposed to it. These two factors alone increase their capacity for pain, which aligns with Dr. Thomas Joyner's theory of suicide risk. They have quick access to lethal means. The profession is predominantly white and male, matching a demographic where the greatest number of suicide deaths occurs in our country. They experience a myriad of stressors to the body and soul. Some researchers refer to this as the police complex trauma spiral. It includes sleep deprivation, schedules that are not conducive to a healthy social life, family life, or regular participation in faith-based communities. Working holidays and weekends when they're not with their own families, and they're answering calls involving substance use, violence, and family dysfunction. They incur moral injuries when witnessing acts that are inhumane, that are incongruent with societal norms, or that exceed their physical or emotional abilities to help. They have a persona that's a helping persona. It is deeply guarded and threatened by the concept of seeking help. They are the first into a crisis, but the last to seek help in a crisis. Here are some things that have exacerbated the risk in the last several years and may have contributed to these headlines. First, isolation. Terminal uniqueness is an expression I use to describe a culture of belief that no one understands police work except another police officer. Healthy relationships with family and friends provide balance to combat the dangers of that narrow line of thinking. But the pandemic and a rise in anti-police sentiment has diminished those supportive touch points in the lives of officers. Work schedules and sleep deprivation have always been problematic. Today, schedules are more erratic than ever. Officers are working long hours to cover mandates and accommodate for staff that are out sick, have died, or have retired. In search of sleep, serenity, and good health for their family, officers basically hibernate when not at work. This has taken away protective factors. Officers suffer in silence, thinking they alone can fix everything, when in fact they themselves may be broken. Secondly, extreme expectations. Earlier, I mentioned the struggle of meeting society's expectations when the expectations are unclear. I also stress that this bright spotlight on law enforcement, from their work on the streets to the policies and procedures that guide them, is warranted. Yet I ask you to consider that the high-profile cases we see of police injustices do not reflect the majority of law enforcement officers. The scrutiny demanded by those who have violated our trust has led to extreme expectations of all law enforcement personnel. Even before these recent events, agencies saw the influx of growing demands for services. To meet them, they scaled down programs, worked with minimum staffing, and collaborated. Officers on the street saw their roles to serve the community expanding. Expectations to be teachers, counselors, mechanics, paramedics, therapists, and even parents to children in need. Doing all of these things perfectly is an extreme expectation. Now factor in public scrutiny and those unclear societal expectations. Top it off with oversight such as dash cams and body cameras. This technology is warranted. Consider, though, the stress you might experience if your entire day was monitored and decisions you made would be available for public review and critique. And thirdly, they feel devalued. All of us need to be engaged in purposeful activity where we feel value and experience belongingness. Faced with increasing anti-police sentiment, it's difficult for an officer to feel valued or purposeful. I mentioned earlier how this is impacting recruitment and retention within agencies. People who would be well suited to the profession are reconsidering. People within the profession are struggling with identity. Who am I? What's expected of me? Is this worth it? And retirements are happening at a record level throughout the country with no equal pipeline of applicants to fill the vacancies. Simply stated, healthy officers contribute to healthy communities. People who are hurting hurt others. To be empathic to the people they serve, to be fully present in a proactive manner, and to break a cycle of implicit bias, they must be well. As one officer stated, quote, "How does a nation expect us to heal our communities when no one is looking to heal us?" End quote. This leads to the last portion of my presentation, Building a strong safety net for officers allows for healing and prevention of mental health conditions. Including this concept in our plan for reform will heal communities. And here are a few examples of how we can be inclusive. Build trust with effective messaging. Language that fits dialogue of the helper mentality, such as, do you need a hand versus you need to get help. Talk about the wear and tear on the brain from trauma. Language that does not criminalize, generalize, or assume law enforcement officers are not capable of needing services. Language that validates the stressors and the risk of poor mental health inherent in helper personalities and their work. And language that offers tools for building resilience. Connect law enforcement departments and personnel with existing services. Things like the innovative crisis intervention that is timely and accessible, like the text options that are available for veterans, or the emotional PPE program that was featured at Mental Health America's National Conference, designed for hospital personnel, might be a great fit for law enforcement also. Expand continuum of care among law enforcement personnel in research and policy change so that they're part of the support and transformation of mental health services for all people. Capitalize on the courageous few in law enforcement who have given testimony and been a witness to living with a mental health condition or surviving a suicide attempt. Promote their message in the general public. It could provide insight and break down perceptions of officers as invincible and incapable of feeling. Aggressively target families of law enforcement, the gatekeepers, by providing educational opportunities, screenings, and resources for them to build their protective factors that in turn can assist the officer. Seek innovative ways to minimize access to means. Firearms are readily available as tools of the trade. Developing programs and messaging that remove that risk without threatening the helping persona or shaming the officer would save lives. Collaborate with existing programs and legislation. Currently, we have some great stuff out there in CISM, Critical Incident Stress Management, CIT, which officers are trained to recognize this in other people. Let's train them to see it in themselves. Peer support teams, EAPs. Trauma-informed therapists are needed for the EAPs that serve law enforcement. Penetrate the police academies at the state or department level. Work with organizations that are the professional groups like IACP, the Chiefs of Police. Look at how we can utilize things like the National Action Alliance for Suicide Prevention, workplace suicide prevention, that actually has a unit for law enforcement. And things like the STOIC Act, supporting and treating officers in crisis. It was a bill that was taken up in 2019, and it revises Department of Justice grants to provide family support services to law enforcement personnel. And lastly, capitalize on the recommendations of President Obama's task force on the 21st century policing. There are many opportunities within that report where we can collaborate. The work of agencies such as MHA and all its partners to secure equality and justice for all Americans is admirable. As we roll up our sleeves and get to work on a critical component of that work, police reform, I ask that you be inclusive and innovative by looking to improve the mental health of the people who protect and serve our nation through law enforcement.
Thank you so much, Mary. We're so pleased you could join us today and that you offered that important presentation to us. You mentioned some things that we've been talking about at MHA for a very long time. We call it chronic stress, and we usually think about it in terms of people who then end up in mental health crisis, but we generally don't think about it for the people who respond, who, as we know, are very often officers. We have been so greatly distressed this year about the rise in officer suicides. And we know that, as you mentioned, having access to lethal means is one of the reasons. And that's a very difficult situation. And we've been talking about it as we go around the country and talking about safe storage of firearms and talking about when you're not feeling well. offering your firearms to somebody else. And that's so hard for an officer to do because that's tools of the trade. What's your advice for an officer who may be feeling suicidal and yet really wants to continue engaging in their profession?
That's a tough question because I do not want to offer legal or professional advice that is outside of the scope of my ability. But I do want to address what I think is happening toward that question. And that is, as we see more innovative and progressive leadership that is acknowledging the fact that this is a tool of the trade, and it will actually often, by removing the weapon or asking them to turn in their firearm, truly that doesn't solve the problem. It doesn't take away the means. There's another way or a mean that an officer can find if they are intent on dying by suicide. And then we also have to try to address or talk with the leadership, and I'm seeing them having more conversations around this, that their decision to remove the officer's weapon or to have them turn in their firearm, is it for the purpose of the officer's safety or is it for liability reasons? And I really ask them to think that through, because if in fact it is for the latter, then we may be exacerbating the situation for the officer and washing hands of the situation. What else can be done? Let's be innovative. And there are programs that are happening that are doing that. And there are many, many ways that we can address that. I just want to mention too, though, when you say the rise in officer suicide, we have to be cautious. There isn't really any specific tracking system for law enforcement suicide. Not yet, nor in fire service or EMS, the other professions I serve. But we do see that it reflects, by anecdotal data and the nonprofits that are gathering it, we see that it generally reflects the fact that our society, adult white males of working age who are dying by suicide, it tends to trend along with that. And so we want to be cautious in sharing that information and simply saying that no matter how many officers die by suicide, or we learn of anecdotally, one is too many.
Couldn't agree with you more, Mary. And we at Mental Health America felt very strongly, very negatively about some of the state legislation that was passed that requires anybody who mentions it to, to have their firearms removed, because that impedes people's position. The types of things that I was thinking about was how an officer could say to a fellow officer, will you hold while I'm off duty? Say to a family member, can we make sure we have a safe in our house? Those types of things that I was thinking about. One of the things that I think, and you touched on this, is talking about screening. And, Mental Health America, we have an amazing screening site. It's free, it's anonymous, and we welcome getting that information out into law enforcement, to getting that out even further. And when I was in Philadelphia, I mentioned in our last, with our last presenter, with Carol Ballard from CIT, I helped bring CIT to Philadelphia. And I was delighted for all the time that I was there to participate in each and every training. We had members of our staff do the role plays with the officers. But I think that the most powerful part of that training was the officers telling their own story, about telling their own struggles with depression, with suicidal thoughts, with even suicide attempts with their fellow officers, and how that really was so helpful to do that. In your training, do you encourage officers to share their stories in those ways?
Absolutely. It does, though, take time to build trust, to chisel away at some of that protective barrier. Again, that helping persona is not willing to come forth with any vulnerability or a sense of failure or inability to do their job. So that is difficult. What I really want to try to teach to law enforcement, whether it's the front line, the academy, the administration, is that mental health is a part of life. And officers shouldn't see mental health as binary. Unfortunately, they do because of the people they work with. It's a the us versus them kind of thing, or you are or you aren't. And I would rather see mental health as a continuum, and they are somewhere on there all the time. And recognize when you're not well. Recognize when you need that chance to tell a friend, I need a hand. But also recognize the joy and the benefit in the way that mental health crises have helped you on the job, have helped you become a better person. Recognize that so they don't see it as a negative aspect, but rather on the job training. And hey, I've been there. I get that. I know that. Been there. And find that joy or the benefit in it so they can more freely discuss it rather than, oops, I went over the line, or oh, I can't trust anybody with this information. And I think we're making some progress there, but I'm kind of in a little bit of a tunnel because I work with just that community, and I'm very, very open and transparent with them.
That's a wonderful note for us to end our chat on, that there's not a them, there's not somebody else, there's all of us. We again appreciate you being with us so very, very much. And we look forward to further collaboration go forward. Our pleasure. And we're going to take a break right now. We are going to have a 8-minute break. We will return promptly at 1:48. Thank you again, folks.
Thank you.
Thank you, Mary. Hello, everyone. Welcome back. We've been hearing about some amazing programs around the country and how we have to, while still police playing an important part of crisis response and how to respond to police who are in need of some help and to make sure that we pay attention to their mental health as well, we're going to now move into looking at some phenomenal programs that are coming out of Denver. One is coming from our MHA in Colorado, Mental Health Colorado, and we're going to hear from Vincent Atchity, who is the Executive Director of Mental Health Colorado. Vincent previously was the Executive Director of the Equitas Project, which was a nonprofit, nonpartisan organization that was working to disentangle mental health and criminal justice. And that's by activating leaders and influencing policy and spurring innovation. And when I use the past tense, Vincent was, now the Equitas Project has joined Mental Health Colorado. And as part of that, Vincent's going to tell us about their program of CARES, Not Cuffs. Then we're going to hear from Chris Richardson. And Chris is with the Denver STAR program, which we have talked about quite a few times during this meeting so far. And Chris is a licensed clinician, and he's worked with the Mental Health Center of Denver for over 15 years. His philosophy is that recovery and well-being are possible for everyone by focusing on the individual's strengths and resiliency. Chris is going to tell us about the pilot, about the STAR program. So I'm going to turn things over to first Vincent and then Chris, and then we'll open it up to have both of them with us for some Q&A.
Hi, I'm Vincent Atchity, President and CEO of Mental Health Colorado, and I'm here today to talk to you about Care Not Cuffs, hashtag Care Not Cuffs. What we're doing is trying to promote a national culture change initiative to prioritize care, not cuffs. Mental Health Colorado is our state's leading advocate in promoting mental wellness, ending shame and discrimination, and ensuring equitable access to mental health and substance use care. Care Not Cuffs is a concept that we want to share with everyone in the country. The idea is that we know what needs to be done. People are doing it. We're going to identify the local heroes who are providing care, not cuffs. We're going to teach the public how to ask for care, not cuffs. And we're going to create demand amongst elected officials for more care, not cuffs, in their communities. As most of you know, jails and prisons have become the largest mental health facilities in the United States, and that is not okay. Care Not Cuffs is all about stopping that, changing that, redirecting people toward health care and making sure that people are getting health care for their health needs, not criminalization and incarceration. Care Not Cuffs is in action, though they don't know it yet. There's Care Not Cuffs initiatives underway all over the country, which we are calling out and identifying as the heroes of this movement, so that others will be able to recognize them and imitate them so that we can get this done. We don't believe that much more study is required. We know what needs to happen in order to make sure that people are getting health care and not criminalization and incarceration. Care Not Cuffs in action happens in crisis response through such things as the CAHOOTS model in Eugene, Oregon, where clinicians respond to calls for healthcare needs rather than police officers. And the consequence is reduced arrests and better health outcomes for all. The CAHOOTS model has been in operation for over a decade and is the inspiration for a number of other similar type projects around the country, such as the Denver STAR program right here where we are based. We would like to see clinical response for healthcare needs far more often. We're holding CAHOOTS up as a hero for Care Not Cuffs and would like to see more of that. We like to see Care Not Cuffs in schools. where rather than harsh disciplinary practices which single out children with unmet health needs and identify them early on as troublemakers, setting them on a path to juvenile justice and later adult justice system involvement, we'd like to see teachers and other staff in educational environments better trained to recognize students' unmet health needs and refer them to appropriate resources, rather than those jarring images of school resource officers or school-based police putting young children in handcuffs and otherwise restraining them for their disruptive behavior. We would like schools all over the country to recognize that care is what's needed when kids are disruptive, not cuffs. In community policing, there are also models for care, not cuffs, where police patrol neighborhoods with which they're familiar, neighborhoods from which they originate as individuals, getting to know their neighbors and understanding the drivers of various people's needs, which may lead to disruptive behaviors, so that these things can be intervened in a proactive way that leads to appropriate resources for care, not cuffs, rather than waiting until it's too late and a crisis, allowing police to intervene in crises with the usual tools of policing. In the justice system, there's all kinds of examples of care, not cuffs. This is where district attorneys and prosecutors all over the country, such as those participating in our prosecution research network, are involved in identifying those who've been charged with crimes whose health needs exceed their criminality and creating pathways to health care, leading to dismissals of charges, better health outcomes, and cost savings for their communities. We applaud the efforts of these right-minded prosecutors to provide care, not cuffs, and we'll be celebrating them as local heroes of this effort. In corrections, there's also care, not cuffs. Progressive-minded Department of Corrections directors, such as our own Dean Williams here in Colorado, understand that if we're not providing care in the context of our correctional facilities, what we're doing is we are creating an endless cycle of failure for people whose behaviors often stem from a lifetime of unmet health needs. It's so important that corrections not just be a euphemistic word, but actually succeed in correcting both people's behaviors and correcting the unmet health needs that have led them down a path that does no good for anyone. In re-entry from the correction system, we also know what needs to happen. People need to be stably housed. They need to be gainfully employed. And above all, perhaps, what they need is continuity of care, whether they're coming out of a short jail stay or a prolonged prison stay. Being released back into the community without continuity of care contributes to recidivism and poor outcomes and an endless cycle of escalating costs for communities. No one should be released to homelessness. No one should be released without immediate warm connection to the kind of healthcare that will help them stabilize and successfully reintegrate in their communities. All kinds of good examples are underway of this kind of care, not cuffs upon reentry, such as the work that the Fortune Society does in New York in providing all kinds of wraparound ongoing services and supports for individuals attempting to reintegrate with their communities and their families. With the right supports and services across the lifespan, support for children, access to housing, employment, especially employment that comes with a living wage, and quality health care, we can yield healthier populations and prevent crises. We need to know how to ask for care, not cuffs. We also need you to support our work. When it comes to asking for care, not cuffs, what most people don't understand until it's too late, that when we call 911, as we've all been trained to do in our distress, but the cause of distress is a mental health issue, rather than a physical health issue such as a stroke or a heart attack, the arrival of the police is not always or reliably shortly followed by the arrival of trained clinicians who are able to de-escalate and stabilize people. Instead, the police manage it, and this leads to cuffs and charges and sometimes injuries, if not fatalities. People calling for help need to stress when they call to the dispatcher that what we're looking for here is care, not cuffs. This is a family member in distress. We need health care. The public also needs to let the elected officials know about the kinds of initiatives that do successfully provide care, not cuffs, and demand their study and adoption within their own communities. The other key thing to do is to use the hashtag when you see care, not cuffs being provided by first responders, members of the law enforcement community. Celebrate them, recognize their effort to do the right thing, and acknowledge it as a care, not cuffs phenomenon. This is what we would like to take off across the country, is the expectation that when we call for a health need, what we get is health care, not criminalization and incarceration, and a long, prolonged nightmare for an individual and a family who really just needed help. We're Mental Health Colorado. We depend on your support to continue doing our work. Please sign a petition. The petition calls for care, not cuffs. We'll circulate it. We'll be circulating this petition with its signatures to elected officials and community leaders all over the country in 2021. We can do better together. Please visit carenotcuffs.org. This is an initiative of Mental Health Colorado, but is offered up to the entire nation as something that we can make happen together. Thanks so much for your time and attention today. I look forward to hearing your questions.
My name is Chris Richardson. I'm the Associate Director of Criminal Justice Services with the Mental Health Center at Denver. And I'm here to talk a little bit about Denver's STAR pilot that just took place in June of 2020. I can give a little bit about historical background. Denver has had a co-responder unit since 2016. That is a unit dedicated of a social worker and a police officer riding together for the entirety of a shift, responding to behavioral health calls that have more of a behavioral health nexus, and being able to really kind of provide support and connection to individuals in the community versus the historical possibility of someone going to jail or hospital being the only solution. So as we kind of grew and developed in our programming over the past 4 years for that, we recognized that there was a ongoing calls that come across 911 that really just don't have a law enforcement nexus. But we keep sending police officers because that's historically what 911 has only had at their disposal. So what we did in 2019 was have a contingent of Denver community members and city agencies get together and start talking about the reality of having a civilian-based unit that could kind of respond to these low-level 911 calls that don't have the law enforcement nexus. So the Mental Health Center at Denver, the Denver Police Department, 911, Denver Justice Project, the Harm Reduction Action Center, Dasher, and Servicio de la Raza all went up to Eugene, Oregon. And I said that correctly, Eugene, Oregon. No one would have thought it, but they have been doing a civilian-based response model for about 20 years now. And we really went up there to kind of pick their brain on how they did it, what they do, and how they're able to be so successful attached with it. Over a 3-day period, we did ride-alongs with them. Our 911 center went and spent an entire day with their comm center, talked with law enforcement, talked with the community, and we're able to take all that information, package it up, and bring it back down to Denver and really start a widespread community discussion on how do we create something like this within the Denver system. As we kind of built this out, I just think Denver is so amazing. We were able to actually apply for Caring for Denver funding in 2017, I believe it was, 2018. The Denver citizens actually voted for a behavioral health tax that's about 25-cent tax on every $100 that goes to kind of innovative behavioral health programming and being able to help bridge the gap of mental health and substance use issues in the community. So lightning kind of just struck at the right time. We were able to actually request for this pilot through that foundation, and we're granted access in 2020 to start a one-person, one paramedic, one clinician, one van pilot in the downtown corridor area, responding to these low-level calls. Now, I'm sure, as everyone is kind of aware, this small thing called COVID-19 happened. So that really kind of impacted our ability to start as fast as we would have liked. We were aiming for April, but that did not happen up to what we were hoping. But we did recognize that during this pandemic, a lot of service providers in the community and a lot of supports for individuals really were changing what they were doing. A lot of people were going virtual. A lot of people didn't have drop-in hours anymore. And there was a really big shakeup attached with people's long-term stability options and supports no longer being accessible sometimes. So as a community, we recognized that we needed to lean into this, and that STAR was going to be that pilot that really allowed us to connect with people and kind of bridge that gap while we kind of serve it, while Denver kind of figured out what its service connection was going to look like. So we started our pilot June 1st, 2020. At 10 o'clock, we keyed up and said, we are in service. And within 2 seconds, we had our first call. And we haven't looked back since then. We've been able to go on, as of November 23rd, 717 behavioral health type calls that have come across 911. During those times, we have actually been able to self-resolve the crisis or situation on the streets without having to add a law enforcement component, meaning we have not had to key up and say, can we get police as backup for any of this? And we've been able to do this with a paramedic and a clinical social worker on the van responding to these. And I think what we've really identified is that individuals in crisis are having one of their worst moments, and that we are able to provide a support or service connection or a kind listening ear to those individuals to be able to resolve whatever it is they're dealing with. And I think the biggest thing that we've noticed is the ability to transport to specific locations, being able to provide whatever might be necessary. And part of that is what we carry on the van, but also to be able to be kind and empathetic to what an individual might be experiencing or going through, and being able to provide that support in person. So June 1st, just to be kind of give some nuts and bolts, our partners, the Denver Police Department actually took a civilian report taking van that they had in storage, and were able to retrofit that to kind of get our service needs for the STAR van. They were able to stock it with food, water, and basic life support stuff that the paramedics could use in a pinch if needed. And then kind of starts as a bad joke. A paramedic and a social worker show up and start responding to 911 calls. And I think the partnership has gone really, really well. And the community members that have been part of this and voicing their thoughts and very intentionally what they can do to help support the STAR van, and what they view as like an expansion of this into 2021 has been huge, and very incredibly outpour of knowledge from every community member that's attached with it. The common calls that we are going on tend to be trespassing, welfare checks, assists, follow-ups, individuals experiencing behavioral health concerns such as mania, psychosis, suicidal ideation. And then, every once in a while we get the individuals that someone else is calling on them, and they're concerned about that individual's safety, and just want someone to touch base with them to see how they're doing. So we're able to provide that. I think one of the biggest things that I am so proud of the city of Denver with is not 4 days into our STAR pilot, Kyle Clark with 9 News actually posted something on his Facebook page saying this is what the city is doing, and if anyone wants to donate to what goes on the van, then please go ahead and do that. And within 24 hours, the city of Denver actually donated $40,000 for supplies on the van. That has really allowed us to kind of build in the things that we just never thought we might need. It's not just food and water, it's sweatpants, it's shirts, it's shoes, it's socks, it's condoms, tampons, sunscreen, hygiene kits, harm reduction action supplies, basically anything we could think of, and to the community that we're servicing, saying, hey, like, it'd be really cool if you had this on the van, and we just look at them and say, you're 100% right, we need to be able to provide that. So really proud of what Denver's created and built, and being able to do this in a way that is responsive to the community and sending the right response is pretty creative, and something Denver should be very proud of. The additional pieces that are kind of those we didn't expect, but are something that is a very positive from where we're coming from, is we've actually had about 25% of our calls are officers that are recognizing that they are on a call that doesn't necessarily have a law enforcement nexus, and them calling the Star Van in to actually respond, and being able to say, this is something that I don't have the skill, system navigation expertise, but I know who does, and being able to tell that citizen, I'm going to call someone in and I'm going to get you the right help, and them, us getting there, us kind of tapping them out, and then being able to provide that service on the spot for that individual. And I think what that does is really, it speaks a lot to the partnerships and community partnerships that we have, and that includes Denver Police Department. And it also helps kind of reinvent what the badge means and what it looks like, and that they're part of the solution, and trying to help an alternative response attached with that. Trying to think of anything else off the top of my head. I think from a kind of how we started this pilot, we are specifically doing our pilot in the downtown corridor area, primarily District 6, and all down Broadway to Alameda, which is the affectionately called the Lollipop pilot. This allowed us to be able to respond pretty effectively to the downtown corridor area. We operate 10 a.m. to 6 p.m. That's where we notice a pretty high call volume ability. And then we're kind of using data to really drive home the idea of, like, when expansion does take place, and expansion is something that we want to get to the entire city of Denver. How are we doing that, and how are we being able to key that up so that we know how many vans we need in one specific area, how many responders do we need, what kind of response do we need, what kind of medical response do we need as well. So as we kind of build this out, community is consistently at the forefront of being able to really expand what this model should look like, and really being creative with what the response should look like, who should be on the van, and how that response should be taken.
Thank you so much, Vincent and Chris, for being with us today. Oops, I see they have your names reversed on there, but I know who you are. We really appreciate you being with us today. It makes so much sense, and just ties together all the important things that we've been hearing. Vincent, we have been hearing lots and lots, and we're going to move to Chris in a minute, about crisis and how we do that, but post-crisis, and for folks who are already in the criminal justice system, just give a tiny little preview of the pilot that's about to happen but got delayed from COVID at Mental Health Colorado with Mental Health America National. So give us your real quick version of that, because we'll feature it at a future meeting.
Sure, thank you. That's the Pathways Home project, and the idea there is that we're collaborating with Patrick Henry with Mental Health America, the national office, and Patrick has been training peers in correctional settings to provide expert care for one another. And so Patrick will be coming out and training a cohort of folks in custody in the Colorado corrections setting, who will then serve as peers and then continue upon their own return to the community to serve as peers and bridge a smoother transition back into community well-being for folks who continue to come out of Department of Corrections. So we're really excited about that training opportunity. It is making the best of things inside and out, I think. So.
Thank you. We think that's so important as we take the sequential intercept model up to intercept 0 with programs like STAR, and then through the very end as folks come out. So we're excited about that. Chris, you talked about things that really matter to people, and that was so evident in the things that you have on your van, so that the listening to people about what they need. Sometimes they need a cup of coffee. Sometimes they need a cigarette. Sometimes they need a clean pair of socks. Sometimes they need personal hygiene products that they haven't been able to get. And so we truly appreciate that. Somebody has asked us through our chat about the criminalization of homelessness. And we know that folks with mental health conditions are sort of getting criminalized too. But you're looking at what it is people need. That's a step towards not criminalizing homelessness and helping people.
Yeah, I think when we're going on this, it's about how do we help individuals being able to get the resource connection and services that otherwise, it's hard for me to make a doctor appointment. For someone that's in acute crisis or having life stressors, being able to get those low barrier things is just something that they can't overcome or have difficulty overcoming. So we're there to kind of be able to provide that like immediate transition to community-based services. Not only from the mental health side, but also from partnerships that we've established within Denver to get those individual services. And then specifically as it ties to homelessness, I think it is also, we go on quite a bit of calls where homelessness is kind of the root of what is being called to 911. And we are actually calling the call taker back and kind of explaining why our response was sent out and kind of educating them on kind of what we're trying to do and how we're trying to do it, and kind of a better utilization than 911 for something of that nature. I think part of this is educating the community of why do we consistently go to 911 just for an annoyance and not because of something that's more acute in nature. And that's a long road to education, but something I think we need to tackle the other side of on these crisis responses.
Absolutely. We're all looking forward to the rollout over the next 2 years of 988, and we hope that those calls will go directly in Denver to the STAR program as it continues. I'm going to throw this question out to both of you, please. So this is a pilot. The STAR program is a pilot in Denver. And what is your recommendation for other communities adopting, as Denver has done, the CAHOOTS model?
I think in all honesty, I think you just have to recognize from multiple parts. It's about how do you connect with a community in a different way? How do you engage them in a different way that is holistic, it's trauma informed, and it's a right response versus traditional response. And then I also think it's recognizing, especially with law enforcement and Department of Safeties, is we're there creating these programs, and these programs are in existence to lighten the load of law enforcement, to kind of take some stuff off their plate that historically has just been adding and adding and adding, and being able to provide them a resource and tool that they can call upon, but can also just nix certain things off theirs that historically just don't need to be there anymore. Just because our system hasn't changed in 100+ years. We're just now getting to the idea of changing and adding to it.
Yeah, and I think that our recommendation is that all communities adopt something like a CAHOOTS or a STAR program model, and it's really about a shift. It's a cultural shift of disposition about humans in the land of liberty and what our expectations should be for and of them, and preferring care and systematically coordinating that care. And so whether it's an exact replica of a program in another city is not what matters. What matters is that shift in disposition, that there should be a clinical, care-oriented response to people's need. And that's a culture change that's underway and is super encouraging. I'm a big fan of Chris's work and think of Chris as one of the local heroes of Care Not Cuffs for sure. And, I think that law enforcement have been some of our key informants behind this, because police and sheriffs know better than most people in the country the extent to which they are fruitlessly using their expertise and time and resources to address an issue that is not their primary area of concern, nor should it be. It's not a public safety issue so much as it is a healthcare access issue.
Thank you. We've had a question that I want to frame around a response that in my conversations with one of our earlier speakers, Dr. Jack Rozelle of Resolve in Western Pennsylvania, has talked about how when they encounter somebody who might have a weapon, it's not a showstopper for them and their mobile teams. And our questioner here would like to know, in the STAR program, what are your protocols in place if you encounter somebody who may have a weapon?
We're going the same kind of thing what the doctor was saying, and a little bit what Carol was saying is I was doing assertive community treatment out in the community by myself, engaging individuals in a different way. And I think if you're engaging them in a different way, the threat concern is not really something you worry about. You're building relationships. And I think at the end of the day, people carry knives for safety, especially if they're in the homeless communities, and people carry, brass knuckle, whatever safety weapon they have. That doesn't mean they're using it on me, and that doesn't mean they're using it on the community. They're using it as a means to protect themselves living on the street. And I think that doesn't negate my ability to build rapport with someone or engage someone in a different way and get the support that they need or asking. And I think, we don't have a full protocol, but we are hiring people that are specifically understanding of, we're not coming at this as from a concern safety, we need to worry about every single person. We're coming at it from a very positive, what can we do to just help you? And I think that helps disarm the individual. It helps us build rapport, and it helps a different conversation. It's not fear-based, it's hope-based.
Excellent. I'm sorry, Vincent, go right ahead.
Just to add, because of the cultural shift that we're thinking of, it's fairly safe to assume, this being America, that any other person you come across is in possession of a deadly weapon. And that doesn't stop us from being neighborly and getting things done in most cases. So yeah, the same principle, I think, applies. Yeah.
An excellent note to stand on to end this conversation, this important conversation, that we're all neighbors, we all live in community, and we're really here to help each other. We so appreciate the work that you both do and the models that Denver and Colorado sets for the rest of the country. So I'm going to say thank you to you, and I'm going to turn things over, speaking of Colorado, to Mo. Going to moderate a panel of our affiliates, and they're going to talk about the needs of indigenous populations and what is happening in their communities to aid those populations. Mo?
Good to be here again with you. And so I am honored and proud to be able to introduce to you two of our affiliates, Montana, Shelley On in Montana, and Carlotta McCleary from North Dakota, and then Dan On, who used to be Mental Health America of Montana's executive director years ago, now has his own enterprise. And so I'm going to be introducing them to talk about what their works are, respectively, in the areas of the country where they are working. Good to see you all. So, hi Dan, haven't seen you in a long time. Carlotta, good to see you again. So I'll introduce Michelle, even though her camera is not on, but I know she's on. Michelle, can you hear us? Okay, perhaps not. Dan, you can hear me, correct?
I can hear you.
Okay, fine. And Carlotta, you can too. Okay. So I'll leave Michelle's bio and introduction to the end, and we'll start with Dan. And Dan On is Senior Program Officer of Empire Health Foundation. He manages the Families Together focus area, which includes numerous initiatives aimed at diminishing children's stay in foster care by 50%. He has a significant footprint in the behavioral health and healthcare capacity building space, tribal engagement with family preservation models, and developments of sustainable strategies for community-based projects. Dan earned dual undergraduate degrees in sociology and social work from Montana State and a master's degree in social work from Denver University. He served as executive director of mental health advocacy in Montana for 8 years, and that was Mental Health America, Montana. Prior to that, he was development director for Open Minds, which is a national behavioral health consultant group. And additionally, he has managed numerous adult and children's behavioral health, both inpatient and outpatient agencies and residential settings across the country, to include Kentucky, North Dakota, Minnesota, and Montana. So welcome, Dan.
Thank you.
Carlotta McCleary has been a tireless mental health advocate since 1994. Her first 9 years, she was the Region 7 parent coordinator for the North Dakota Federation of Families for Children's Mental Health before becoming the organization's executive director in 2003. Carlotta then became the executive director of Mental Health America of North Dakota in 2014 and is currently the executive director for both Mental Health America and the the North Dakota Federation of Family for Children's Mental Health. She has served on numerous local, regional, and state boards and committees and testifies at the state legislature with the singular purpose to improve mental health services in North Dakota for children, adults, and their families. Currently, Carlotta serves on the State Hospital Governing Board, the North Dakota Olmstead Commission, the North Dakota Behavioral Health Planning Council, the Alliance for Children's Justice, the PAMI Council, and is the spokesperson for the North Dakota Mental Health Advocacy Network, and has no spare time, I'm sure. So welcome to both of you, and hopefully we'll get Shelley shortly. We wanted to focus this particular part of the conference today on indigenous peoples and what is going on in your various states with regard to people of color and indigenous people. Earlier, I had mentioned in the introduction earlier today that the Western States region of Mental Health America, which is our policy cluster, we have some differences from other states, block of states, I should say, in the nation, in that we have large geographic areas, large rural areas, and we have higher numbers of indigenous folks than many other states do in the East. And so I'd like to begin with Dan, if you would be. So Dan, can you tell us more about what you're doing in working with the tribal agencies that you are engaged with?
Sure. Thanks, Mo, and great to see you again. Hi, Carlotta. It's been a long time. The work I'm engaged in and have been probably the last 10 years is about building behavioral health capacity in indigenous communities, reservations across the country, from Alaska down to Georgia, and particularly Montana, and now the last year focusing pretty heavily on Washington State, at least the eastern part of the state. And much of the work is because there's a huge opportunity for tribal nations to access a high encounter rate for behavioral health services, and to, in a sense, build a delivery system that becomes an economic engine within the community. And in that, the encounter rate today is $479 per encounter, where if you're in a nonprofit providing mental health services or substance use, you're probably going to get somewhere between $60 and $100 for an hour. And an encounter in a tribal community is really based on the integrity of the engagement. So whether it's 15 minutes or 8 hours, you're going to get paid the same. So part of the work has been helping the communities understand the opportunity, build the infrastructure for it, and begin to, in that, also incorporate cultural, traditional healing practices as a part of it, so that the delivery system looks like them and is not a Western model, but rather an intersect of Western and cultural practices. The the focus over the last year has really been on a family treatment model whereby serving the family, whether in an outreach to their home or whether in a residential based, an urban based facility where we bring families who are in justice involved, maybe a drug or alcohol involved, and are at risk of losing their children. So how to sustain the family in an intense treatment model that's 6 months long, and steps down to a transitional living environment that's another 6 months, and then back into the community. So it's been building a continuum of care from everything from an investment of about $25 million in a residential treatment center, to prevention services in communities around culture building, around workforce development. I will say that in the last year with the pandemic, and particularly in Eastern Washington, devastating fires in the fall, that the communities are very closed down right now. They're shut down for practical purposes, not to spread the virus, but they're shut down politically, and they're shut down in terms of what I would call a great risk aversion within the communities, that because of the political issues that relate to loss of revenue from their gaming institutions to employment opportunities, there's a great deal of caution, suspicion, and so what has been an environment where you need to build relationships, it's been much more difficult to sustain the relationships, to sustain the level of trust, to have folks take risk. So it's not a matter of money. You could throw money there. Nothing's going to happen at this moment because of how shut down they are. So it's really a matter of continuing at this point, just trying to nurture relationships, keep them alive so that when we're at that point where there's some sense of safety and some ability to move about, we can expand some of the initiatives. But it's an environment that's ripe for increasing access to care, increasing revenue to health systems, and developing workforce that looks like the community. And the use of peers as a substantial piece of that is really significant. And in two of the projects, we're actually developing integrated health models, or integrated cultural health models, where the delivery looks very much like practices in with our culture. That's involved bringing elders to the table and others in the community who have PhDs, and trying to marrying the culture with Western models so that they can certainly access payment systems, but actually have something that feels and looks more like their history and who they want to be. So I'll stop there, Mo.
Thank you. How since we have a little time here, how did oh, there she is! Hooray, Michelle, you're with us. Well, then I'll go ahead and save the questions for the end then, and we'll continue now that we have Michelle back with us. Carlotta, let's go to you, and you have something very exciting that's going on in North Dakota that's really terrific about the juvenile justice system. So please tell us about that.
That's correct, Mo. One of the things that happened back in 2014 and just a little bit prior, we had a lot of reports like the Schulte report, Behavioral Stakeholders report, that were really reporting that North Dakota was in a mental health crisis. After that report was produced, the legislature then commissioned the Human Services Research Institute to really take a look at an assessment and to do some processes that needed to be followed through on to really correct that crisis. So during that time, we also developed a Children's Behavioral Health Task Force to really take a look at what were the issues that children were facing. And through that task force, in a following session in 2017, the Juvenile Justice Commission was, along with the Children's Commission, were designated in law to start meeting and take a look at the children's services and then also what was happening in juvenile justice. Prior to those things, our state focused in on the adult population with justice. There were reports of 2/3 of the judges were sentencing people to prison in order to gain access to mental health services or behavioral health services. So very similar traits within our children population. 79% of the juvenile justice population had a serious emotional disorder. And so that is really, really high. While Native American populations represent 5.5% of our population, there is an overrepresentation of Native American youth in our juvenile justice system as well. Most of the kids in the juvenile justice system have a dual status, meaning that they're either involved in child welfare and then they become involved in juvenile justice. And so in that particular population, 23.3% of that population, again, an overrepresentation, are actually children that are Native American. So the commission went to work and they were going to chart a 6-year commission to really fix and focus in on what was needed, to really gather information around child welfare, education, abuse and neglect. But what ended up happening is they brought in the Council for State Governments, and they visited in February of 2020 and again in April. And they really said that there's a need to update and restructure and align with research, that they needed to do something with the justice system. So again, thinking that it was a 6-year process, Representative Clamine, who chairs the Justice Interim Committee, really decided that, you know what, we need a bill and we need to do this now. We're not going to wait 6 years to improve the system. So they set out on a bill, and it really completely rewrites our juvenile justice laws in North Dakota. And right now that bill has, the interim committee has all approved the bill, and it will be moving on to the session this year. And what it really does, some of the things that the changes are going to be happening, we're just like updating the definitions, clarifying roles and responsibilities. But the most important piece is renaming what they would consider unruly children to be children in need of services. So instead of charging children and sending them into the justice system, they are now going to be diverting those children and having them go into services. At the same time, because of the HSRI also looked at a lot of services in North Dakota that need to be for mental health, they redesigned the county social service system into 19 different zones, and really are looking at operating completely differently in our state. So with that, those children will be going to then those social service zones to be getting access to services, to mental health services. These are something that has been very, very low services. We've been serving 400 children in the past few years, 400 to 800 children that have serious emotional disorders in our mental health system. And when you're looking at prevalence rates, we have 18,000 children who could be in need of services that have a serious emotional disorder. So you can really see our mental health system was not serving the children, and the children were going into the justice system. So we're also going to be doing a 1915I state plan amendment, which will be creating more services, more community-based services for children that have a serious emotional disorder. So again, it's limiting, it's also going to be very narrowly defining what the delinquency is. and determining what a delinquent child. So you would have unruly and delinquent children in our juvenile justice codes, and so it's going to be very narrowly defining what actually a delinquent child is and isn't, because we've been having too many referrals going from the school system, as an example, and the schools are also going to be limited and have to provide more efforts before they can refer a student into the courts. And so again, this is just going to be totally rewriting and redoing things. So children will really make a big impact in our school to prison pipeline for our children. Really taking things, making sure that they're looking at what those needs of those children are and giving them access to services rather than routing them into our justice system. So those are huge changes here in North Dakota, and we're very, very excited about them.
Well, thank you, and thank you for your advocacy, because I know you've been fighting for things like this ever since I've known you. For the last 10 years I've met you, you've been fighting for better access to care for children, so really appreciate your efforts. It's wonderful to see something come to fruition, isn't it?
It is.
And welcome, Michelle, and I wanted to read just a little bit of your bio. So Michelle Ani has been with Mental Health America of Montana for 11 years and Executive Director of Mental Health America of Montana since 2016. Michelle's work is focused on prevention and advocacy across Montana, particularly how to utilize virtual tools to allow for Montanans to connect with supportive health options. Mental Health America of Montana has a virtual drop-in center. It's called the Montana Warm Line, and they have a youth diversion mentoring service. The development of the new service, Montana's COVID-19 Disaster Plan, is their Montana Crisis Recovery Project, which reaches out to help with COVID-19 isolation throughout Montana. She has had success providing services for youth in Northeast Montana, working with law enforcement, youth probation, schools, clergy, and families, and community health experience in and throughout the state. She is very knowledgeable and understanding of the Montana mental health advocacy and delivery system. So, Michelle, welcome, and I'm glad that you could join us, and we're very interested in hearing about your outreach efforts.
Thank you. I'm really happy to be here as well. Sounds like most of all our MHA have really been a go-getter and getting out there to advocate for their states and so forth. So I can tell you a little bit about our warm line, our Montana warm line. It's been running for a little over 13 years now, and it's all virtual. With most warm lines throughout all the other states. And when the COVID hit in March here in Montana, and we all went into a shutdown, we stepped up and we extended our hours. So instead of our warm line being open from 4 in the afternoon to 10 at night, we opened our lines from 8 in the morning to 10 at night, Monday through Friday. And then we were open from 12 noon to 10 p.m. Saturday and Sunday. We also reached out to all the communities throughout Montana for those that had lost their jobs, and hired on about 13 new employees to help reach those gaps that we weren't reaching into, especially the rural areas, northwest Montana, and some western areas that we weren't reaching as well. And I think that we did a pretty good job of reaching to those that didn't really know about us or know about the line. And since we opened back up, we did lose a few people here and there, but we still gained with those communities that we hadn't reached before. So that was a big, huge reach for us. We have been working with the state on a disaster plan. We've been
asking the state to do a disaster plan for over 10 years now, because we really didn't have one here in Montana. So this was a great push to help with that disaster plan. So we helped with the crisis counseling here in Montana, and it was just for whatever disaster is going on in your state. And as we're trying to get this up and running, we ended up having some fires, and we couldn't reach out to those individuals. So I feel kind of defeated in some areas that we couldn't reach to, but now we're up and running and capturing those that are back into the isolation with COVID, and as well as helping those individuals that are still affected by those fires that did happen here, kind of about the same time that we shut down the state. So it was a good reach, a good solution, and we're hoping that we can continue using this disaster plan for whatever kind of disaster that does come forward. So. And to give you a little bit of data on our warm line, we went a good triple amount of calls throughout the month since we've been shut down, or since we have the COVID since March. So we've tripled our numbers every month, just getting those individuals that were isolated or depressed. We find that we are getting a lot more callers that have had substance abuse. So trying to get those individuals into those treatment centers, or to even get that kind of help that is well needed, is again another great reach, because we rarely had those callers. So now knowing that those callers are calling into the line and seeking help is great for Montana, period. So that's kind of about what we have been doing since the pandemic. It's been a fast path for us. You know, I kind of feel like we do 24/7 with not just our lines, but reaching out to, the communities, what their needs are, how we can step in to fill in that gap, how we can partner. The other thing is that we were starting back our annual conference, which is kind of a bummer, because it was going to happen this year, and then COVID hit, and then we had to shut down our annual conference. But we're hoping to learn a little bit more about the virtual fundraiser platforms, which we were part of that meeting yesterday. So we're hoping to kind of pick up that slack and get into that virtual world of conference and seeing where that kind of pulls us. Overall, I think that we've done pretty well to help Montanans with whatever kind of disaster or whatever mental well-being is going on. I still feel that there's a much bigger reach of getting those absolutely rural areas to call in or to get that help. Because as we know, just like North Dakota, you don't have those rural areas. They don't have, the hospitals. They don't have the behavioral health centers, right? And they have to travel hours away to get that kind of individual help, let alone our kids. So it's a long trail, a long path for all of us, and we're hoping that we can do a much better plan here in Montana to help.
Thank you very much. I have several questions for you all, and we have about 9 minutes or so for question and answer, so we have a little bit of time. I wanted to go back with Shelley, broadband access. So you have expanded your broadband, which is wonderful, but are there areas in the state where broadband is not able to be applied because there just isn't the technology set up? the infrastructure set up to reach. And I'm thinking particularly of the Native American reservation areas.
Yeah, absolutely. Thank you. Absolutely. In one of those, one of the part of the plan for our disaster is grouping with Kaufman and Associates that does have that contact with the Native Americans, and so we're very excited to be working with them so that we can reach to the Native Americans, and we're excited about doing that, and we're hoping that we can offer some kind of place near the future, down the future, to continue that relationship. So we will be offering 2 positions for the Native Americans on our crisis counseling line. So that was that whole partnership with Kaufman and Associates, is to reach to that area, and we're going to hire on a few people that they feel is qualified or could be doing this outreach into their own communities, because they know their communities well.
Right.
It's not my place to go in and say what is needed when they know what is needed. So we're excited about that, as well as working with the Hospital Association here in Montana to hire on 2 healthcare workers to help the essential workers.
Terrific. Great. You formed some good partnerships. That's wonderful. Yeah.
Thank
Do you have a feeling for how you're going to keep this a sustainable project? Funding is always the problem, and you talked about the virtual fundraisers that you're looking into and that kind of thing. So is this a shared financing mechanism with the hospitals and Kaufman and yourself?
Yep. So right now it's a grant funded by FEMA and SAMHSA, and we're hoping to continue that funding through them. That is another part of that grant, but we're going to continue to do what we're doing. I think partnering with the state and knowing that this is their disaster plan, that we will have to find, those shared partners to come in to help with that funding. But right now it's through a grant. We're hoping that the community will see value in what we're doing and step up and kind of help with that.
Great. Super. Terrific. Dan, there's been a couple of questions for you. To describe a little bit more in detail what you are working on with the Native American populations, do you think that the pandemic has increased awareness amongst Native Americans, or the discrimination against being able to reach Native Americans in terms of mental health? Are the tribes resistant to mental health because of stigma, that kind of thing?
Yeah, sure. Certainly the pandemic and the social unrest and social injustice has impacted the tribal communities. And in some ways, it's not necessarily been a bad thing, in that that's created a stronger identity to community and a stronger desire to have delivery systems that look like who they are, that have providers that are native, and that they're more self-sufficient, since it strengthened their sovereign nation kind of view of the world, which the hard part is, if you do not have a relationship with them, if you're not working in sort of tandem with them, and say the tribal affairs division for the healthcare authority or Medicaid, it's harder to make things happen. So relationships, the intertribal, interstate governmental relationships become real important. I think if you look at, back to your question about is there stigma, it's easier if you're Native to identify with a substance use disorder diagnoses than it is for a mental health diagnosis. So there's rampant stigma. The way through that, though, is through the use of peers, working with elder communities, and really getting into the schools. So lots of ways to work with folks who have an identified lived experience. And certainly they, as communities, they're well aware of trauma, historical trauma, intergenerational trauma. And to work from that base, that sort of begins to mitigate the feelings or the stigma around mental health. So it's really working within their structures and their experiences in the world. And the pandemic has struck hard because this relates to them back to their first contact with the white world, with Europeans, and significant portions of their community being decimated by disease and viruses. So this is a much bigger thing for them than it might be for us in terms of the historical trauma and that first contact.
Very good points. Thank you. I have a final question for all three of you, quickly. What would you like to see implemented or increased in your state to make things better for the people you serve? And I'll start with Carlotta.
You know, I would have to go with increased mental health services. That is still an issue. We're waiting right now for CMS to approve our state plan amendment. But we still lack many basic services, crisis response, just even access to doctors to be able to do medication. So anyway, I would just say increase services so that we can keep our children and our adults out of the justice system needlessly when it's just a symptom of their disorder.
Shelley?
Yeah, you know, I'm going to go with a youth mobile crisis unit. We had a speaker at one of our conference many years ago that had talked about how they actually had got this youth mobile crisis unit up and running, and how enjoyable it was because they can literally go from school to school to school and get the services that the youth need. The one thing, one of many things that Montana lacks is that we have nothing and we're doing nothing for our youth. And this would be a huge impact to the communities to help with our youth so that we're not sending our youth away out of state or even sending them out of their community. So definitely that.
Dan, 30 seconds because we're out of time.
Yeah, I'm going to say that one of the big things we're working on right now is looking at the feasibility of a managed care organization run by tribes, so that the operational pieces, rather than having to go through state government or state Medicaid divisions, that they have a tribal managed care org. So it's more infrastructure and operation when it comes to the tribal communities.
Terrific. Well, thank you all three very much for being on our panel. This was terrific, very informative, and it's exciting to see what the affiliates are doing in your various states. And we really appreciate all your work because it makes a difference. Thank you. And so with that, I'm going to get back to Debbie.
Thank you, Mo. Thank you to our affiliates. I'm so humbled by the work that you do and so proud of the work that we do at Mental Health America National to help all our affiliates and help them learn from each other and bring in wonderful experts and to partner with them. We're also, again, so grateful to our industry partners that helped us make the Regional Policy Council possible: Allergan, AbbVie, Janssen, Myriad Genetics, Neurocrine Biosciences, Otska America, Sage Therapeutics, Takeda Lundbeck Alliance, and Teva. I'm all incredibly grateful for the people that helped us make this meeting possible, the people who do the behind the scenes work and the people who've been in front of it. A big shout out to Karen, our advocacy manager, who you all saw during our program to honor legislators. And again, a thank you to Council of State Governments and to the other national legislator organizations for allowing us to be friends and partners. I want to say thank you to Catherine Reynolds for helping us do all of the coordination for the website. I want to say thank you to Whitney Ball and Taylor Adams, who helped us with our chat today. A super big shout out to Sachin Doshi, who is our webmaster at making all of this possible. And a big thank you to Amanda Adams Barney, who has been our consultant on working virtually and getting all of our pieces together. We really appreciate you being here with us today. I want to give you a tiny little preview of our next meeting on February the 12th. Mark your calendars. Everybody will be getting a save the date where we'll be honoring governors who have been mental health champions, as we've done for the last 5 years. And we're going to do something really special, and we need all of your help for this. We're going to be having a legislator town hall. So not only will we be having our affiliates, our friends, our partners, and we want to invite the mental health authorities from all of the states, but we're asking you to please invite your legislators, because we'll be talking about why mental health is so important in every piece of legislation they do, why it figures in, why it's important for their community, for their states budgets, and all of those important things. So please do join us on February 12th. And I have one final ask. Being that it's Giving Tuesday, please do help us meet that $50,000 match from Hot Topics Foundation. It really means a lot to us, and it helps us do all the wonderful work that we do at Mental Health America, our advocacy work, our screening work, our policy work, our social media, and so much more. So again, thank you so much for joining us. We really do love having you with us, and we look forward to when we can meet in person again.